Hi, good morning, everyone. We're going to get started so that we can end on time and everyone can get home and catch their flights on time. I hope you all had a great evening yesterday. I know it's a really cool neighborhood and there are lots of great places to hang out, and I hope you had a fun evening last night. So this morning we complete our great lineup of speakers and content. I've heard great feedback from yesterday from everybody and hope that's true. You'll see that on every seat there's a questionnaire, pretty simple one-sheet questionnaire on the conference, and it would be great if you could jot down some thoughts and turn them back in at registration, at the registration table before you leave. That's so helpful for us each year. You know, so that's one of the most important things that we can get from you. We end at about 12:30 today. And again, Jeff and I are here throughout the rest of the conference if you have any questions. And so now we're just going to kick off the first panel. And I'll bring Rex back on. Thank you.
Okay, good morning. Was anyone not at the 515 last night? Everybody was, right? I think so. So we're going to jump right in. And our first panel is new product innovations designed to boost care quality and performance scores. So if you guys want to come on up, we have three panelists for this, and I'm going to be actually moderating this one. So it's Anshul Falcon, Vice President, Strategy and Business Development from Icario. And maybe if you can help us understand how to pronounce, is it Icario? Icario? Which one? Icario. Okay, Icario. Josh Hoover, Regional Sales Leader from Amplifone Hearing Healthcare. And Dev Mukherjee, SVP of Revenue from Duos Living. So before I get started with questions, I'm going to give each of them a quick opportunity to give just a slightly more in-depth introduction of themselves, so you know who's up here. Okay, so Josh, you want to start?
Thank you. Josh Hoover. I am the National Business Development Executive, or one of them, for Amplifone Hearing Healthcare. Amplifone is a global organization, one of the leaders in the world of providing hearing aids to people across the world. In the United States, we are well known by our brick and mortar locations, Miracle-Ear, and we work with health plans to help manage hearing loss in the Medicare Advantage space. We work and make plans and develop plans and innovate plans to get members hearing aids to help with STAR measures and risks like risk of falls.
Good morning, everyone. Anshul Falcon, VP of Strategy and Business Development at Icario. Yes, don't worry, it's a tricky way to pronounce it, right? But actually, part of the name is in reference to an island in Greece called Ikaria, which is known as a blue zone area. And for those of you who may or may not know, a lot of the blue zone areas have been studied extensively to understand how people have aged, and the longevity of those areas are far above other parts of the world. And so our inspiration in that name is, you know, we work with health plans to help their members live healthier lives. And to do that, it requires them to go in to get care, hopefully preventatively, and better education of the wonderful benefits a health plan offers. And so what we help is outreach, multi-channel outreach, bringing our data science and behavioral science expertise and making sure we're personalizing how to encourage someone to take a health action in their personalized journey. So that's what we do, based out of Minneapolis, and excited to be here with this panel to chat more.
Awesome. Dev Mukherjee, I lead revenue at Duos Living. Think of Duos Living as a personal assistance model to drive SDOH and care gaps for Medicare Advantage populations as well as caregivers. We pair stay-at-home moms and dads with these older adults and their caregivers to have weekly interactions, and we can talk a little bit more about that, but weekly interactions to uncover what their barriers to care are, and then leveraging both the plan design as well as their local community resources, we're closing those gaps.
Great, thanks. So I have a few questions I'm going to ask these people, but I would encourage all of you to, this is, as we think about innovation and its importance in STARS quality in general, right? Ways to kind of stretch what we've maybe historically done and focus more on kind of the art of the possible, right? But they have some great examples, I know, but I would encourage you to think about some questions you have too, and let's definitely capitalize on the Q&A session at the end and benefit from them and their companies and the things that they're doing as examples of innovation out there. So I just wanted to prep you for that if you can think of anything. So the questions I have, right? So number one, pretty high level here, but can each of you describe some examples of real innovation that are happening in the market today that impacts STARS specifically? Josh, I'll start with you on this one.
Thanks, Rex. So innovation's really important all across health plans, and we've taken innovation very seriously at Amplifone. Taking a look at the different STARS measures that are out there that you need to be concerned with. The C13 measure, reducing risk of falls, is over the past 3 years been the lowest rated on average STAR measure for health plans, far lower than many of the other metrics. And that's one of the primary areas that your hearing vendor like Amplifone can make a huge impact for your plan. And the status quo out there is basically seeing that measure go down farther and farther every year. Amplifone has innovated some really great hearing healthcare plans that engage members, not only getting them to buy hearing aids, but finding ways to help them understand how to use them, when to use them, to help with that risk of fall metric. If you're not wearing your hearing aid, even if you own one, it's not going to help with your balance and other issues that cause risk of falls. So innovating new plans, finding ways to get members engaged, doing things like remote testing, remote monitoring of hearing aids to know when members are wearing them, what situations they're wearing them in, and then to further educate them on proper usage of hearing aids will actually help those measures, and as a result, produce a better rating in that particular metric. And there are some other metrics that hearing health can help with as well. But looking at your vendors overall and knowing what areas they can help with and are they up to par or helping your plan do better is a really big question and good question to look at when you're considering, not only your hearing vendor, but any other vendor you're working with.
And I'm imagining that innovation, this is just not necessarily a fact, but just a thought, but when you think of falls prevention, there are certain measures, right, that are so much broader than the actual measure itself, or have such a more broad impact. So falls prevention, readmissions, the flu shot, right, that impact quality of life in so many pieces of the health plan too, right? I mean, it's even through MLR. It feels like those might be really good places to innovate, right? Like not that a certain measure that's more hyper focused on something wouldn't be, but it feels like falls prevention would be a great place to do some pretty extensive innovation.
Any of those ratings that are typically low, and that particular one being the lowest measure of all of them, there's really areas for improvement. So plans that want to maintain that 5-star rating with all of the new stuff that's out there saying we can't continue to have all these 5-star plans. There needs to be a differentiator between plans, and STARS is the way to do it. And if 80% of plans are making a 5-star rating, it really dilutes that quite a bit. So we all know that it's going to be more difficult for plans to maintain that and keep those 5 stars in the future. So finding those metrics that have a lot of room for improvement are going to be important.
For sure. Anshul?
Yeah. I'll add that the, shifts we talked about yesterday, really looking at member experience and that 2 to 4 waiting shift, we've just seen a dramatic change in, not just doing that one measure, doing it at a point in time. It's much more look at the holistic annual calendar even before they become a member. What things can we do to learn about somebody before they're enrolled in our health plan? So that when they enroll, that first interaction is a phenomenal interaction. And so that the emphasis upstream even is something we're continuing to see new ideas that some of our clients are asking us to push and innovate, and we'll bring data to the table, data that is not the healthcare view of someone. It is everything but the healthcare view. It's their socioeconomic status, their information on, do they have cats or pets, and are they a dog person or cat? And I joke, but those are real analytics about who someone is, why they choose one plan maybe over the other, and what they're looking for from their healthcare. So we're seeing a huge appetite in broadening the question of not just hitting a 4-star on this measure and this measure, but as you said, the interrelatedness of it is asking us to do more end to end. So it's really exciting as we're seeing that shift from our clients and our needs. We're able to bring concepts you guys see everywhere else in your life, right? The rising consumer demand's not going away. When do you choose to fly United versus Delta? How's their network? Is there a layover? Okay, maybe not. I'll take the direct flight. How is the price? Which one's cheaper? Which route do I go? I'm a loyalty member in the Delta program. I get to board first. Maybe that aspect of it makes me choose differently. And the proliferation we're seeing in the supplemental benefits, whether they be hearing aids, what Duos provides, care support, that's part of the tangible examples this year, next year, of how the network benefit design is innovating the experience. So those are all areas we're seeing tremendous demand, and will help educate the members to, did you know this is there at the right time when you need it, and really activate them into taking advantage of some of those innovations and being able to measure it. Some will not work, some will not be as valuable as another benefit. So those are a few of the dynamics we're seeing play out, and helping support our health plans on all of those is what we're doing.
I think, just real quick, Deb, I think what you said around, I think it's important for us when we're thinking about innovation, right, to realize innovations. I think many of us usually think it's a product, or it's something that you buy, or it's a new iPhone, right, or it's something, or it's a new supplemental benefit. But it can be, and I think you were kind of alluding to this initially, right, like just like having a new focus, or like a relentless determination, right, to learn more about the new member. So when I think about, like, we've been doing a lot of studies on member retention because it's a huge topic right now. And one of the things that obviously is a hugely important thing to do is to have a deeper understanding of where they came from. So like all the consumerism data, the social determinants data that Anshul mentioned, also just understanding, did they come from a commercial PPO plan where they didn't have any medical management, they had a broad network, and now they're enrolled in a Medicare HMO, and we need to really understand that when we're signing them up and onboarding them and managing their expectations. Like that's innovation too, right? It's just the new process, a new understanding. I just kind of wanted to hammer that one home because I thought it was a great point. But yeah, Dev, go ahead.
Yeah, super well said, Anshul. I would add to that we're noticing more and more plans asking us, give us as much SDOH insights as possible, because number one, we have trouble engaging with the hardest to reach. And number two, now I think plans are getting their head around using that SDOH data to make better decisions around their plan design. How do you optimize your supplemental benefits depending on what those members care about? And then how do you kind of drive that towards higher retention and of course higher growth in the super competitive markets as well. At Duos, when we're having these weekly interactions, we're trying to get an understanding of, yes, the classic HEDIS measures that we can drive on, whether it's the annual wellness visit requirements or any of the med cost saving drivers as well. But just as importantly, if not now, becoming increasingly more important, is how do we incorporate experience into the workflow, and how do we kind of report back to the plan proactively around issues that are going to hit this member earlier on, so that the plan can kind of prepare for those CAP surveys.
Great. The second question, and Anshul, we'll start with you on this one, okay? As innovation leaders, can each of you describe some accelerators and decelerators for innovation?
Yeah, I'll actually say the regulatory changes, oddly, are the accelerator, not the decelerator, as we look to next year. It's specific on the DSNP membership. We do a lot for that membership via our health plan clients, and the final rule and the requirement to say, hey, we are going to collect this SDOH data as we do a health risk assessment is a big milestone. It's pushing us to not just have those as nice to have things so I should preface by saying we do a lot of health risk assessment on behalf of our health plans. We help support their specific needs, and adding those types of questions is just one other way to collect data and act on it. And so at the time of getting that survey response in real time, if it's a web survey, we're immediately triaging individuals back to the health plan's resources for their expressed needs, for the food, housing, or transportation resources that they might have identified. So it's, not the paper version you fill out and maybe hear months later. And as we know from yesterday, you got to hear it at least 7 or 8 times for someone remembers. So it's that first moment and then the continued moment from there to get that person involved and engaged. So
To kind of add to that, I would even say that plans are thinking about how to balance their CAP/HEDIS priorities with retention and growth priorities. As plans are going into more competitive markets, you see, of course, the rise of tech-enabled MA startups as well, which are offering a different set of value propositions than the traditional MA plans as well. And thinking about how the supplemental benefit design with better education around it drives better retention and better growth to compete in those markets, I think are some of the accelerators for sure. Yeah.
And I'll jump in on the decelerators. I think the biggest decelerator we see in the marketplace is the status quo. Plans that just want to push the easy button because it's what they've always done. In hearing healthcare in the past 5-6 years, it's been a one-size-fits-all benefit. Everybody does the same thing, not realizing that there are a lot of different reasons for plans to innovate and do something different in that marketplace. So it's, a check the box. Yep, we got a hearing benefit. Yes, we have this benefit. Yes, we have this benefit, and not looking at those benefits on a regular basis to say, what has come up in the marketplace that's better? How could a plan that's different be better for our members and, have impacts on our ratings and results?
I think those are all great points, and I love this question, and I didn't come up with this question, so I can say that. But and I think if I'm a health plan, right, it's really important for me to understand what my accelerators and decelerators are currently in this kind of current environment in the marketplace and internally in my organization too. Because to understand kind of where my organization is coming from, if funding is obviously not always adequate, right? So we have to prioritize. And if we're expanding into new markets, if we are leveraging national call center brokers for the first time, and we haven't had to do that before, that presents new challenges from an engagement and retention and standpoint. So there are lots of places where, we have kind of new challenges now, and Anshul mentioned the D-SNPs, right? And who all here is a D-SNP, by the way, or has a D-SNP? So quite a few, right? So congratulations on being CMS's newest crush. It's the final rule was personalized for you guys, so it felt like. But yeah, lots of change in the regulations and lots of opportunity in lots of places. But to understand kind of where our organizations are is super important. Okay. Activation. We touched on this just a bit, but I want to go a little deeper here. Activation, it's a big topic with a lot of my clients, I know. And by activation, getting members activated in their plan, in their benefits, and their supplemental benefits, right? The whole 9 yards, but really getting them to feel like they're really part of this and have some vested interest in the plan itself. Big topic as it relates to experience and retention, caps, the whole 9 yards. Do you have examples of what activation might look like? Dev, I'll start with you.
Yeah, sure. So at Duos, success for us with our partners is, of course, driving HEDIS measures, depending on what their priorities are. Could be the traditional triple-weighted RX adherence, could be fall risk, could be others as well as caps. But a leading indicator to show that success over time is definitely driving member activation. And a couple ways that we're doing this. Once we kind of understand the population we're going after with the health plan, we'll kind of deploy a set of marketing tactics, both traditional and digital tactics. Perhaps to no one's shock, we've seen more and more data around social media being huge in the older adults category. I guess all these folks are now on Facebook, and they love using it, and it's kind of worked to great effect for us. Leveraging a series of marketing tactics and then creating this scalable yet personalized experience up front, where we're having an upfront conversation with them to understand who they are and what their needs are initially, to personalize their ongoing experience with us, enables us to have that high activation rates that we're able to drive. And again, like, as much as plans, of course, want to hold us accountable to driving HEDIS and CAPS goals, a lot of that data doesn't get shown until, aligned with the calendar year, right, over 12 months. For us to kind of show those leading indicators, activation is absolutely front and center.
Josh?
Yeah, I would say marketing is always the key to activating members and getting them to understand the benefits, particularly within hearing, to know the benefit exists, how it looks, what it means for the member, where they need to go. And I would say activation really even begins before enrollment, when you're selling to the members, to listen to the members and what the members in your demographics are saying they want. Pointing directly at hearing again, just because that's where my experience here is. Differentiating a plan, knowing that 40% of your members are looking at your hearing benefits within your Medicare Advantage plans. Doing something different, showing a better benefit in that area is going to increase enrollment and increase member engagement. So
I'm going to follow up real quick on that one, because you mentioned something I think is really important, but the how it starts in the sales process, right? So the sales, I've seen studies, and I cite this all the time. There's a study that shows that from a retention standpoint, the likelihood of a member staying with your plan is determined across, let's say, 4 key touch points, right? So with like 20 to 25% being in their customer service interactions, 20 to 25% being in their access to care experience, 20 to 25% being in the onboarding, but 30% being in the sales experience, right? So the likelihood of them staying with you is most significantly driven by what happens in the sales experience. And that activation, I totally agree. Like, and plans are getting there, right? We're seeing more plans move it up, but yes, that sales experience, working with the brokers, the agents, the e-brokers, the national call center brokers, Yeah, it's critically important, Anshul.
Yeah, I'll just add, I mean, everything we do is to help activate a member to do something, whether that's a measure or not a measure. And so how we do that is really melding a lot of the data science you heard me talk about and targeting with really specific studies that we've done around behavioral science, why someone would be likely to take an at-home colon test versus go in for the in-office. And the way some of the programming we're supporting clients around this is bringing to bear how to think about motivation and behavior change. And sometimes that requires a reward, a $10 gift card. Maybe what gets that person. Doesn't matter their income level or education level sometimes. You'd be shocked to see just knowing that it's good for me to get a colon cancer screening may not lead to just doing that. But that incentive, that extra little card to Starbucks or wherever may drive that activation. And so we do a lot, what we're doing more newly, given some of the supplemental benefit innovation, is almost tying those rewards back to sometimes a benefit. So it's a different way to think about it and different way the funding levers play, but certainly something to explore. And this is more of a Medicaid example, but I think it illustrates the point well, where for preventive checkups, postpartum checkups, the Medicaid individual, by completing them, can go ahead and redeem for things like strollers and diapers. And so it's really matching some things that might be free benefits at the time in a very different flow, but we're all human. The reward motivation methods that we heard yesterday talk about are effective. Doesn't mean it needs to be everywhere all the time. It's who needs it and who might be that requires that to activate a broader part of your membership. So those are parts of what we're seeing and experimenting and continuously learning, but definitely the benefits and the type of reward is something to explore further. I'd say in your organizations, is that marketing? Maybe it's not, actually. It might be in my MLR anyway. So.
One thing I'll just add, a different part of activation that we've seen is where these members are coming from and signing up with. And I think, Josh, you were talking about this before. 20% of the conversations we have are with the caregiver of the older adult. And half of those conversations are with caregivers that were signing up that member on their behalf. Right. So a lot of times these plans may deem those members as retention risks because they were signed by their caregiver. They might not have known exactly why they were signed up for that specific plan and what benefits they had access to. So engaging with those set of caregivers to understand what those needs are, as well as understand, help the MA plan understand the retention risks of those members definitely helps, not just with the activation up front, but the retention over time.
Yeah, the caregiver experience, that brings a whole new challenge to activating the member, right? Is there anything specific you guys are seeing there? I mean, as far as what do you do, how do you get around that, or how do you address that when you're talking to the caregiver and trying to activate the member?
Yeah, I mean, I think it's obviously understanding that the audience is quite different. These are younger folks who are perhaps less interested in having weekly live calls and video calls, which is our core model of what we do, and want to kind of have conversations over digital methods, and we've kind of built that out now. And I think these caregivers can provide different data points than the member can. So we've done a bunch of research to understand what types of questions should we be asking the caregiver versus the member, so that we're telling the MA plan the right set of data based on who we're talking to.
And it's very commonplace in hearing healthcare that we're working with a caregiver because the patient or the member can't hear very well and has a very difficult time having a phone conversation. So a majority of the time we're working with caregivers on the front end of the member experience, which is very important to the whole process.
And if I'm a health plan thinking of, like, I'm just imagining even the collaterals, right? I'm imagining maybe specific caregiver collaterals that don't exist maybe in a lot of health plans now, right? But that would like help equip the caregiver to activate the member, right? To, not using that language obviously, but to inform them and equip them, right? To help the member get the hearing aid benefits, et cetera. We've touched on the caps and the member experience weights increasing, but I want to at least see if you have other thoughts on this. So how has that shift across all the member experience measures? You know, the fact that it's jumped from 35-40% up to 60-ish% now for most plans. How has that manifested itself in regard to innovation? Josh.
I'll jump on that real quick. At Amplifone, we do a CAP style survey to all of our members that come in and purchase hearing aids. And seeing the results of those surveys and educating the members on the actual CAP survey that they may see and may fill out is really important to getting the results that the health plan wants in there. What we see in our results is better results for the plans that we work with than the comparative plans that we don't work with. And bringing that out to prospective plans or new plans is it's always a really good conversation to say, is your vendor doing better than your current, is a prospective vendor doing better than your existing vendor, and what is that going to mean for your plan? And doing, a CAP style survey is a really good way we found to show and differentiate what we do versus others.
Makes sense.
I'll add a different angle where the weighting, right, has empowered the voice of the consumer to be worth a higher amount on the scorecard. And that shift, as we collect CAPS-like surveys on behalf of our health plans, it's the analytics and insights around them that are equally important. And what we've seen is showing that in the provider lens is really been a useful collaboration where some of our partners are bringing in their provider network team and sharing feedback on the members, and down to a provider level perhaps where there might be discrepancies or challenges. And I think the panel yesterday on CAPS touched on, that's great that the plan is surveying. There's always the provider that will survey too and have hopefully the right discussion on what they're hearing from their patients and members. And so that's where the shift, we're seeing, plans not just doing that and saying, great, we're doing well, we're going to get to 4-star, or we're feeling good, but taking it the added step to share it with the network side, the provider side, because that's a big part of the member experience that you may feel like you don't control based on who they go to see, but there's ways to influence and collaborate with data and insights. And should we make changes in our rate structure or networks? And so it's just the starting point, it feels like, but just even hearing those discussions surface is very, very rewarding to see.
Yeah, at Duos, when we're kind of uncovering and then closing these SDOH gaps, inherently we're driving a lot of those CAP measures that plans care so much about. Identifying when a member hasn't gone to their primary care doctor and needs that to be scheduled, identifying when someone needs their drugs to be filled and that it should be mail order instead of pickup because there's transportation barriers in play. I think we've realized that obviously experience is something that is a priority for every member. Of course, you can't predict who's going to actually get the actual survey. So doing effective service delivery at scale is something that we hear so many plans talk about, and we've made that a core of what we do.
Okay, the final rule, we talked about this a bit too, but the final rule had many new requirements, especially for DSNPs, like we mentioned, right? And some are regarding data collection for social determinants of health, social risk factors, et cetera. What are some examples of innovative solutions focused on that? Anshul, I'll start with you.
Yeah. So we're helping plans do that today already. If you have a need to survey and immediately connect through the surveying to your resources, multi-channel, print, email, IVR, however is best to reach that. That is an area we do today, and where we're extending further to support our clients is, you know, foundationally, there might be areas such as digital literacy that are the precursor to using things like telehealth, which is wonderful to have. And so collaborating on our end with some partners and resources to bring that at that time, right? Oh, do you need help with that? Televisit, that's Zoom. And since we have that point in time on behalf of our plans to work with their members, it's that triage point to say, how can we then support you in these things that may not feel like your health benefit? They aren't, but they are the barriers. And this is something we've collected over the decades worth of working with members, millions and millions of members, is what are the different barriers they have in their ability to take that healthcare action, and realizing we got to address those. Yes, some of them are social determinant in health. There's others that are just, you know, a little bit on the periphery, this digital literacy. What role do you guys see your plans playing in solving that, or partnering to solve for that? Because without those, you know, barriers removed, it's really hard to go even get that telehealth visit. So those are some of the ways, while it's focused on DSNP at the time, it's a really complex membership to solve for. And if we can knock out a lot of those challenges in a scalable way, as you said, and find a way to do that, you could see that easily cascading through MA and Medicaid in time.
Yeah, I think, you know, as we kind of uncover those SDOH care gaps, we're also getting an understanding of a plan's benefit designs and really doing a lot of in-depth research around the members' specific local community and the resources that they have access to. We do a lot of work to kind of combine what those discoveries we make around the SDOH gaps that every member has, and then how do we kind of leverage those resources on their behalf to kind of tie those two things together, again, at scale, all in the name of driving, of course, HEDIS and CAPS. But at the same time, plans are realizing, to Anshul's point, that it's not just the care gaps that we need to think about. It's this older adult has issues around their technology. They don't know how to use their smartphone. They don't know how to use the patient portal. Well, what if there was someone that is focused on creating a relationship with that person over a period of several months or several years, perhaps, where it's a safe space for that person to talk about those personal issues that they might have.
I will say that DSNP is an interesting challenge within our marketplace with state-specific hearing aid regulations. The one-size-fits-all hearing marketplace that's been in existence for the past decade does not work. We really need to innovate plans. We need to know the specifics of the marketplace and build a plan that works. And there are challenges, you know, in this population, including income challenges, that make even having a hearing benefit, a usable hearing benefit for those members, much more important to offer good quality products at prices they can afford within the plan parameters.
Great, thanks. I have one or two more questions, but I'm actually going to open it up to the audience if we can. If you have, does anyone have any questions that they want to ask the panel around innovation? So, so actually, let's talk for a second about pilots, because we talked about this a little bit. But curious if you have thoughts on helping the plans in the audience here. Maybe they're dealing with funding priorities, right, and juggling lots of vendors, and trying to determine sort of the sweet spot where they can really make a difference and do some creative things where they had, but within their capacity, right? So I know, I talk to my clients about piloting, right, and the importance of that from an innovation standpoint. Do you have maybe some thoughts to share with them on ways to build case studies or ways to, or things that you've seen be successful within plans, things plans have done that have, from a pilot standpoint, that have helped make a difference or generate a case? We did not prep for this question. I just kind of thought of this one, so.
Sure,
Go ahead, jump in.
I could definitely take that. So a couple ways we tend to work with health plans. If depending on kind of what time period of the calendar year we're coming in at, we'll start off as a care management program or pilot. Some of the metrics that we'll kind of focus on is, of course, the leading indicators of activation, leading indicators around the service requests that we're closing, what percentage of caregivers we're talking to, and then kind of structuring data around how we show impact, of course, on HEDIS and or CAPS. Generally, with health plans, we've seen them the following year embed us within their supplemental benefit design or SSBCI benefits. We have partnerships with a lot of the different leading partners in each of the SDOH categories, be it transportation, financial assistance, just to name a few. And we're embedding ourselves within those partnerships. We're essentially creating a marketplace where members have access to a wallet and they can kind of drive those dollars to certain benefits that they need that's personal to them based on the plan design. So generally start off as a care management program, then that evolves to supplemental benefit filing.
Great. Any other thoughts on that?
I can jump in real quick. I would say a lot of what we've done at Amplifone in the last couple of years could be considered pilots. We've tried to come in and disrupt an industry that has been a check-the-box status quo industry, and we have some really good health plan data plans that we've worked with over the last couple of years that show excessively better results than what most plans are seeing based on looking at the plan-specific needs, the member-specific needs, and creating and innovating a hearing healthcare plan that works for the population versus just one that's really structured to drive a specific manufacturer's products into every member's hand. So there's a lot of really good results there that show your hearing healthcare plan can differentiate your plan and result in much better results. So we've done a lot of new programs in the last couple of years to really show that there is a big impact in that area.
I think, from the number of vendors to scan across, right, and think about how to best work with whom and for how long and what to measure, where we've seen the best success of the partnership is excitement to lean in and learn versus know that may be the perfect solution right away. And the reason I say that is the type of service perhaps we're bringing is behavior change. And that's a tough process and time, and everyone's different. And so where we've seen really the impact outsized in our multi-year relationships with our clients is diving in with that deeper amount of, well, here's our membership today, here's where we want to get to, might be very different. We may not have it, for example, a decent membership. Do we want one? Do we want to grow there? And starting there helps us develop the best approach that's multi-year in nature. Because if you think about member experience, I mean, that's, if you're looking at the long game around that, there's a different approach entirely. And if you're not, there's ways to go solve it too. I think we heard lots of good examples yesterday, but keeping that alignment of expectation will help you be a champion within your organization if you're trying something totally crazy or different, but also help you have a good partner to make you be successful in that, right? So I'd say those are some of the examples in choosing, procuring. It's a long process everywhere, we know, but I think we're here to be able to deliver and experiment and improve. So keeping that in mind helps it go further.
Great, good stuff. Anything that I should have asked that I didn't, that you guys want to say? We covered a lot, so if not, we're good. Any questions from the audience? Okay. People finished 5 minutes early. That's good. Okay, thanks. Thanks so much, guys.
Thank
Good
you.
checks. So we're not completely finished. Okay, lots of people got to leave. Okay, we're going to jump right into our next session here. We're good, right? So we have, so the next session is on the Meaningful Measures Initiative. So we're gonna get into HEDIS here, HEDIS and digital and ECDS, et cetera. So this is, it's gonna be myself and Catherine Iskrant. So Catherine, I'll give a quick intro, and then when you get up here, you can maybe share a little bit more. But Catherine is the practice leader at Healthy People, HEDIS audit firm. And she's my favorite HEDIS auditor, by the way, so if I can say that. Yeah, so looking forward to this presentation. I'm gonna take just the first few minutes and kind of stay high level from a STARS impact standpoint, but I'm gonna save a lot of time for Catherine to really get in the weeds here on digital measures and meaningful measures, et cetera. Okay, so, okay. And for, I mean, I've been here a couple of days, right? So I think you know me, but I'm mainly a STARS consultant. So I lead a small consulting firm, have a small team working with me. We work with a lot of health plans around all things quality. Creating cultures of quality is really our focus, what we do. You know, heavily around STARS, but also Medicaid marketplace, health equity, et cetera. And then Catherine, as I mentioned, president of Healthy People, one of the deepest experts in HEDIS that you'll find, and somebody I definitely rely on a lot. So there we go. So from a meaningful measure standpoint, I just want to stress a couple of things here. And actually, I'll use my little laser here. And this is straight from the STARS technical notes, right? So I think a lot of people, you don't really understand what are meaningful measures, what are digital, they don't understand what are digital measures, but what is meaningful measures, right? And, it's a framework from CMS, right, that really focuses on the highest priority areas for quality measurement and improvement, including, and these are the key areas here, promoting effective communication and coordination of care, promoting effective prevention and treatment of chronic disease, working with communities to promote best practices of healthy living, making care affordable, making care safer by reducing harm caused by the delivery of care, and strengthening person and family engagement as partners in their care. These are really the things that STARS is founded on, right? So But that's when we talk about meaningful measures from CMS, that's what we're talking about, that framework that we keep in mind, which is essentially what's on the left here, and sort of what's different for digital measures, right? So they complement the CMS meaningful measures. So right now, we obviously don't have a ton of digital measures, right? Current measures per NCQA, they don't really address outcomes like we need them to, and social determinants of health like we need them to. They count visits and they address, processes instead of outcomes. And these digital measures that we're moving to, they will be more meaningful. I think we all know that, right? They'll carry so much more value and so much more information, focus more on outcomes and social determinants of health. So again, I'm going to spend just a couple of minutes here on health equity and sort of connecting the dots here. But really, how will it impact STARS, and what actions do you need to prepare? I'm not going to read all this, but there's a whole lot of text in here that's going to be, I think, really valuable for all of you, right? There are really three key areas, when CMS talks about health equity, and it's really around data collection, which you will see in here, right? Collecting more and improved data on race, ethnicity, and social determinants of health. We've I think heard that referred to quite a bit yesterday, but that is the movement. And then also, measure development that tackles disparities in care, right? So addressing health disparities. So these new measures that we're talking about, the social risk screening and things like that, right? Where we are focused on not just data collection, but actually methodological enhancements and actually developing new measures that will help us address disparities. And then last is really driving value in the Medicare program, right? I think anything we can do there is going to be CMS's focus, obviously. So just a couple of quick things here. As we talk about health equity, so lots of information on this from the advance notice and the final notice, right? The final rate announcement, right? Where developing a health equity index, a lot of this is still proposed, but we know it's coming, right? We know it's getting there. And not to get too deep into this because we touched on a lot about it yesterday, right? But the goal is really to improve health equity by incentivizing contracts, incentivizing health plans to perform well for these socially at-risk beneficiaries. There's not been a lot of incentive there, but CMS knows well and has experienced the impact of incentives to health plans, right? That's what STARS is. It's a pretty, I think, ingeniously designed incentive program, just like we do for members and providers, right? This is how CMS gets us to do things. And looking at possibly using the area deprivation index, which I think will be meaningful, and stratifying STARS, across a few different realms from an income standpoint and social risk factor standpoint. And then the health equity, index, again, potentially coming. Still in the works, still being proposed, still feedback will be provided on it, and it'll continue to be revamped, I think. There is a framework now that's proposed. I think what's most impactful here potentially is the fact that it might replace the reward factor. And this is where it's really meaningful here in two ways, because it's going to meaningfully help some plans, but it's going to, I think, meaningfully, hurt some plans too, right? So this is going to, just like shifting the weights in the member experience measures, shifted priorities within health plans and focus within health plans, somewhat away from maybe HEDIS and med adherence and things like that to some of these more member experience drivers. This is really going to shift our focus to members with social risk factors, because to get a reward factor, if this went through, you would have to have a minimum percentage of enrollees with social risk factors and meet a minimum score on the index, right? So, that makes me believe that many plans who don't have members with social risk factors will lose the ability to get a reward factor, right? And right now, I have a lot of clients who, especially like if they're 4.5 stars, they rely on a 0.4 R factor to get to 4.5 stars, right? So without that reward factor, they still might be 4 stars, but that's still a pretty big hit, right? Maybe not financially, but for other reasons, PR being one. So this is really significant, and it's being proposed. It's likely coming, maybe not just like this, but something to definitely be thinking about. And then just quickly on this is something that's happening too, right? Where CMS is testing risk adjustment for socioeconomic status and sociodemographic status for all of the med-adherence measures. And this is something that's happening in the in PQA and CMS, right? Or have plenty of recommendations here, but I think this is, most people think, a good thing, right? And then on HEDIS, and we had some discussions, I know even dinner last night about this, but currently 4 HEDIS star measures are stratified by SES, so breast cancer, colorectal cancer, diabetes eye exam, and plan all-cause readmissions. And if your plan is interested in obtaining SES stratification data for other HEDIS measures, your HEDIS auditor can work with you. And Catherine has a lot more information on this if we need it later. And I won't go deep here, but the fact here, right, is that the NCQA SES categories they're not an exact match with CMS, and they do need to be aggregated to match CMS. So something to keep in mind, right? And then a pretty important, new development coming is this social needs screening tool, where CMS is looking to create this, and this is straight from the advance notice and final notice, right? The final rate announcement. As far as around housing instability, food insecurity, transportation needs, utility needs, and interpersonal safety. So, and not just to screen on it, but I think we touched on this yesterday, right? Where you have to, likely you're going to have to prove that you did something for the members who scored a certain way on the screening tool. And then I think this is maybe last for me, but how can your plan prepare for that social needs screening, right? So obviously assess your plan's compliance with the screening in the following areas, like we touched on, housing instability, food insecurity, transportation needs, utility needs, and interpersonal safety. And then we talked, I think, about this yesterday too, but the race and ethnicity stratification. So CMS has provided CMS or race and ethnicity stratification data. In measurement year 2022, 3 HEDIS measures will be stratified by race and ethnicity. So colorectal, controlling high blood pressure, and A1C. Measurement year 2023 will have 5 or more additional measures with race and ethnicity stratification across all product lines. In 2024, we'll have 10 or more. Right, so lots of helpful data coming here. With that, I think I turn it over to Catherine, right? So Catherine, feel free to give a quick, more deep intro of yourself if you want, and then jump right in. This is forward, backward, and laser.
Good to know your directions. Thank you. Good morning, everyone. So Rex has done a great job guiding us through the CMS meaningful measures. So Rex knows STARS as well as anyone. He does a fantastic job. I'm practice leader at one of the 9 HEDIS audit firms, Healthy People, so I'll do the HEDIS part of the presentation. So I know many of you out there know HEDIS very well and may work in HEDIS. Even if HEDIS isn't your area, the things we're going to be talking about that you need to do okay on HEDIS, you're going to need to do overall to perform well on the STARS. So my lens may be more HEDIS, but the general approaches to improving your rates and scores, I mean, they're not the caps, tips, and tricks, but they're things you're gonna have to do for risk adjustment, for other STARS that are calculated with PDE data, et cetera. So If you're not wearing a HEDIS hat, this is still very relevant. And a lot of it's high level about structural changes you'll need to make. So we do get into the weeds, but I do talk pretty quickly. So bear with us even if you're not HEDIS. So again, Rex went over the meaningful measures and how they're quite parallel to the HEDIS measures. And next we're going to focus on the NCQA digital measures, how they impact the stars, and what actions you need to take to prepare. Onto that clicker. Okay, so NCQA's HEDIS measures are measures that they write and provide as computer code. They have 22 such measures released already. They can be reported as early as next year, although I wouldn't be surprised if there were only 1 or 2 plans that did it across the nation as a pilot, because they're not yet due. And because they're provided as computer code, either the plan has to pay or your HEDIS vendor would have to pay, and then you would have to pay them for using it. So it actually adds to your HEDIS cost at this point in time rather than reducing it. But it's important to know that you could officially be doing this as a plan next year for whatever subset of the 22 apply to your product lines, Medicare and others. So we've still got many more measures left in HEDIS, about 2/3 to go. NCQA is going to continue converting those measures to digital, or if they don't fit the digital model, they'll retire them and replace them. And so the big takeaway for all of us, whether we're HEDIS hat people or not, is the hybrid measures, which are so much a part of the Medicare stars in the HEDIS set, are going to be retired eventually because digital measures don't support manual sample review of charts. And if you have questions while we're going through, please feel free to interject. So here are the 22 measures that have been released so far by NCQA on this slide and also our next slide. So again, all of these slides will be available in 3 to 5 or 6 days. So a lot of these are reference materials to take back to the office if they're of interest to you. So we'll go through them, but you will have them electronically in a few days. So on the topic of retiring HEDIS measures, NCQA has been working at that for quite a while. They're retiring them and replacing them with administrative measures. So the last official hybrid measure that will ever exist is transitions of care, which came about MY 2018. And the reason it was created as a hybrid, even though NCQA didn't want any more hybrids, was that 2 of the numerators for admit notification and discharge information provision have no associated medical code. So there was no choice. It was a measure CMS and other stakeholders wanted, critically important area of care. So 2018, MY 2018, last hybrid you're ever gonna see created for HEDIS. And similarly, they're not Medicare, but we're trying to show the pattern of what's coming. 3 well child visits were retired by NCQA, and that happened in MY 2020. So for reference, because STAR measures and HEDIS measures, they're like 2 years off. June 15, yesterday, you finished reporting MY 2021. So next June, you're reporting MY 2022, which is on calendar year 2022. We're in the 6th month of that. So just a level set on HEDIS years versus STAR years. So MY 2020, we lost 3 well child measures, and they were replaced, now reported administratively under 2 new measures, W30 and WCV. So we're just going over the pattern here. In MY 2020, kidney health evaluation for patients with diabetes was developed, and it's replacing the now retired nephropathy monitoring numerator of the comprehensive diabetes care measure. So as HEDIS folks know, KAD is administrative reporting. It's 2 lab tests. You can't go hybrid like you could for CDC nephropathy monitoring, which was just retired as of yesterday for reporting. And then for SNP plans, and we know there are a lot of DSNP plans here and others, advanced care planning, which is not just SNP, Medicare, is now replacing, as of MY 2022, care for older adults, advanced care planning, and yes, COA ACP let you go hybrid. Now you can't sample, it's all of your members. So one final change just on the overall pattern. Because colorectal cancer screening is now dropping down to 45 years of age as the lower limit instead of the 50 it's been, now Medicaid is reporting COL as well. And unlike every other product line with this new change, they aren't allowed to go hybrid. So these were not all Medicare measures, but we're trying to show the pattern that hybrid is being retired, new admins are coming out, and you're losing your hybrid option. So transitioning away from how we're losing hybrid, and we'll continue to, let's take a look at the electronic clinical data system measures. It's a great segue to digital measure reporting because it requires much of the same digital data that the digital measures will when you begin to report them. So this slide presents the ECDS measures that have been developed and the last two about to be developed by NCQA. So what's the importance of these ECDS measures? Well, it's not Medicare, but prenatal immunization status has been required for reporting since MY 2021, which went final yesterday, for accredited commercial and Medicaid plans. And then in 2023, breast cancer screening will be retired, and it has to be the ECDS version, so that's Medicare Star. And follow-up care for kids prescribed ADHD meds, not Medicare, but that will be required MY 2023, retiring the non-ECDS version. And then here's our big scare point. Colorectal cancer screening, MY 2024, you lose the hybrid. So your HEDIS team has to do everything they can to get all of your colorectal cancer screening data via EHR administratively or year-round chart review. You lose your sample of 411. That's a huge threat to the stars right there, losing hybrid in MY 2024. So besides COL, well, that's actually the second threat. What are our two main challenges reporting ECDS? Well, measures that have a hybrid counterpart, ECDS measures with a hybrid counterpart, are eventually going to be required, and we're going to lose the hybrid option, and the traditional measures will be retired. So here are the measures. So for Medicare, colorectal cancer screening, like we were just saying, is your big obstacle when you lose hybrid, and other product lines we see there as well. The other main challenge is that the depression and alcohol ECDS screening measures, there are 6 across all product lines, fewer for Medicare, require LOINC codes, and those are not a part of claims. So you do need EHR data for that. And then, as we've been talking about yesterday and today, the new MY 2023 social needs screening measure requires LOINC codes for the numerator for screenings, but it's almost exclusively SNOMED codes for the intervention codes. And those two are not part of claims. So without medical group EHR to get the LOINC and SNOMED codes, we're not going to fare well here. So you have some years, but there's no doubt that these depression and alcohol measures, and probably before then the social needs screening, are going to go display and then star. At least social needs screening is the projection. So again, if you're not HEDIS, just knowing that without the EHR data that was discussed yesterday by our Wisconsin friends and Brent, you're not going to fare well. So social needs screening and intervention, a recap. So there's a lot of CMS information out. Rex went over some. We talked about it yesterday. The HEDIS measure is probably going to be a star eventually because it exists and it's starting in MY 2023. So every year, all your measure members need to screen for unmet food, housing, and transportation needs. If they screen positive in that same year, you have to do an intervention with them. The measure is only out for public comment. So this is kind of some HEDIS jargon, but basically NCQA said last year, hey, we're thinking about coming up with this measure. Tell us what you think. So basically the feedback was, we like it, or we know this is coming, so okay, we agree, but you don't have too many screening tools. They're very limited. So NCQA has let us know that in MY 2023, they won't announce a list, but there'll be many more screening tools. So we've heard from a lot of plans, we do this, but those aren't our tools, the ones they listed. You'll probably be fine. So it's just really important that we need these LOINC and SNOMED codes, and then at the bottom, as was said yesterday, 2023 final rule, you do have to ask at least one HRI question on these topics. So another one, this is huge for all of us, adult immunization status. It's proposed to become the source of truth for adult immunizations. So right now we're using CAPS. That's slated, we don't know what year, to go away, and your adult immunization status is going to come from this ECDS measure. Well, that's problematic because during CAPS, we know only some members choose to answer, but if you ask someone if they had an immunization, you're going to get more accurate data. It's subject to bias and recall errors. You'll get better data than if you say, well, I'm not going to ask you, I'm going to see if your plan has CVX codes from EHRs, because there are not a ton of claims billing adult immunizations. I'm going to see if you've got an adult registry, immunization registry in your state. Even if you do, different states differ on how much they enter for adults. I believe it's Texas where if a member doesn't sign a waiver, the registry isn't allowed to record or pass the adult immunization. So, asking members, did you have it? A small percent may not remember, but saying, well, health plan, if you don't have the EHR data and a registry with good adult immunization, these rates are really, frankly, going to plummet. So HEDIS are not, pay quite good attention here. Just a little hint if you want to go for gold. All your network EHRs have the current version of the CVX code so that you're going to get full credit for any immunizations that they have recorded there. So this is a big thing to worry about whether you're on the HEDIS team or not. So one question we get a lot is, for those who report HEDIS, use claims, admin, chart review data, but what about supplemental data, other feeds you gather, like your CMS MTMP program and SNPs care management, et cetera. Anything you're using as supplemental data for HEDIS, traditional measures you can use for ECDS. It's just that you have to recategorize it or map it to one of the 4 allowed ECDS reporting categories, which are in the little table here. So if you have supplemental data, it's not going away, it just needs recategorized. And it often maps to this clinical registry. So having toured the ECDS, what are these proposed HEDIS digital measures? And again, it's a good indication of where CMS may go with any measures of theirs that aren't HEDIS. So we've got 4 stars here that are hybrid right now, because in the middle we've got eye exams and HbA1c, and comprehensive diabetes care measure becomes 3 measures next year. It's broken out. So this is 4 measures. CBP, right now, you're looking for the last blood pressure of the year. Well, as we're going electronic and you're going to have many blood pressures in your EHR data, they're looking to change to taking the average over time, which might be the measurement year or a different period, but you can see that's going digital. Find me the last one in the chart, give me the average of all of them. Eye exams and HbA1c. So HbA1c going the same way. If you've got the electronic data, let's look at HbA1c control over time, not the last of the year. And eye exams, that's going to be hard because the measure says you get credit if it happened in the year. You could also get credit if it happened 2 years ago, but only if the member didn't have retinopathy. Well, if you go on the chart, you don't always see what retinopathy was because the PCP is saying, yes, eye exam, they don't always give the results. So that's a bit of a challenge because you do get eye exam claims or have vision vendor, but retinopathy status gets you credit 2 years ago. So it is a push to be going digital. And then care for older adults, they're looking at taking those indicators digital too, which means if you look at your star care for older adults, if you've got a SNP for those indicators, how much lift did you get from chart review? Know that you're about to lose that. How can you keep your rates high? So those were the 4 current hybrid measures that may be replaced with digital. This standalone slide is a non-hybrid measure, a new admin, looking at kidney health. 3 main things. Test patients at risk for CKD, management of patients with CKD, and management of patients with ESRD. So again, more nuance on the slide. You'll have them electronically in just a bit. So those are new HEDIS digital measures in the pipeline. Will they all come out? Will they be modified? We'll have to wait and see, just like a CMS meaningful measure propositions. But how do we prepare for digital HEDIS? And our argument is that it's the same for CMS meaningful measures in many ways. So we're moving away from claim-centric measures to measures that really require standardized electronic clinical data if you want to perform well. And the main challenge, if you're not a vertical organization, as much of the data you needed resides outside your health plan in basically siloed or partially siloed systems. So we have to go interoperable, as Brent and others were speaking about yesterday. And although we don't have to be exactly real time to report HEDIS, we really can't have data siloed. And we will talk about speeding up receipt of data, not to real time, but to get a little faster. So clearly, gather EHR and HIE data across your network. Brent was talking yesterday about CCDs. That's really EHR and HIE, just different form of the extract. So just wanted to tie those together for you. Important to educate your network that HEDIS performance is transitioning to digital, that's not a thing, and you'll have increased data needs from them based on this change. And do hit up the point, the hybrids are going away. We used to ask you for all these charts, or SciOx did, or someone else. We're gonna need that data administratively or some other way because they're going away. And look at your contracts. For new and renewal contracts, are you requiring digital data submission? It's not quite as important if it's value-based because they're shooting themselves in the foot if they don't give it to you. But if it's not a value-based contract, that contract really has to have teeth and require digital data submission to help ensure your success. So again, on value-based contracts. So that's really a great way to increase the incentive on the provider and delegate side to get you the data that you need. I believe it's 61% of payments in 2020 were value-based payments in some form or another. And of note, of course, CMS is very interested in these value-based contracts, and they're proposing to develop a CMS star measure on value-based contracts and the nuances thereof. So everything's dovetailing together. So breaking down the silos, let's look at that a little more deeply. So we're going to look at medical group and vendor EHRs, HIEs, and paper charts. So medical group and vendor HIEs. So map out your plan network. You may have already, but your network could have changed a little. If it's outdated, look again. How many groups do you have EHR feeds from? How many groups don't you have a feed from? And what's the size of their assigned membership panel? You don't necessarily want to go at them one by one, because a group with a smaller panel might say, yeah, I can give you EHR data right now. So we would recommend reaching out to all of them at the same time, but then if you have to prioritize because they're not already or need some technical assistance, obviously probably to your advantage to go to the bigger groups first in terms of their membership panel with you. So for EHR, it's a new era, we're going digital. So the office isn't digital. Can you put software in their offices? Here's some kinds, value-based, EHR. We were talking yesterday that Athena Health, Cerner, Epic are ready to go with interoperability. If they have an HIR that we call not optimized for HEDIS data capture, but you might also say not optimized to go interoperable, as Brent was speaking about yesterday, are you going to switch up their EHR software on them or let them know that they need to? And it's not just medical groups. So we need EHR feeds. Vision vendors for files with retinopathy status. That could be a 5 to 7% hit on your diabetes measure when you can't go hybrid if you're not getting a vision vendor file with retinopathy status as a field. Home visit vendor files, yes, you get them, but do they have all the HEDIS measures? Maybe have them do more in the home. They do many and they don't to all plans report back. We're going digital, get the data. And lab files with lab values included. That sounds like a no-brainer and most plans do it. When we talk to our clients, oh, I got Quest, oh, I got LabCorp. Okay, but your delegates, some of them have their own labs or hospitals have a lab, and most plans that we work with, they're getting their big labs, their direct contracts. What about their hospital and medical group labs? Or just, hey, health plan and the EHR want your lab. So there's a lot of missing lab data. If you're hitting your main contracts, you didn't hit it all. And again, when you go digital, you don't have the chart review opportunity to get it. So I know it seems like, yeah, I got labs, but hey, how many labs do you have underneath your delegates? So that was EHR data. Let's talk about HIEs. So HIEs, they're really important. They're covering 92% of the US population to at least some extent. Now, is that all their data? No, but hey, that's a pretty good stat. They can really reduce significantly, they can reduce missing health data. So in California, there was a study of one of their EHRs. They've got a lot. Oh, we're in California. Hey, here in the state of California, Manifest Medics HIE did a review of some of the plans that purchased their data and health plans, so they either had no supplemental EHR data or very little. Those plans reduced their HEDIS chart chases by over half when they purchased or contracted with the HIE for data. So if you've got a lot of EHR data, you're not going to drop by half, but that's how powerful this data can be for actual HEDIS hybrid measures. So it's really important, though, when we talk about HIE to know what you're up against in the HEDIS audit. So EHR data, not really too hard to pass. You give the auditor a sample in the first year you use it. It usually matches a database. If it doesn't match the EHR and you start early, you can keep trying again. Very rare that an EHR database is going to fail. If anything happens, it might be like, okay, you can't use one field because it wasn't mapped right. You can add that in next year, but not too much risk. HIE, there's huge, huge risk. The good news is you only have to audit it almost generally just in the first year of use for HEDIS. So NCQA does have a data aggregator validation program, and HIEs and other electronic standardized feeds can contract with them and pay them to get approved, and then they're deemed, and your HEDIS auditor will leave you alone. So we do have a session downloadable, so 3 to 5 days. If you want to look at HIEs by state and which are NCQA data aggregator validation approved for MI 2021, which ended yesterday, you'll have a good idea as to in your state with these EHRs or HIEs, because they're both actually in there, approved for use. But do keep in mind the MI 2022 list isn't out yet. So, you know, if you've got a vendor in your state who isn't, you could call them and say, were you planning on joining this program? Because it would make your life easier. But what's hard about passing is that the use auditors, we have to follow the NCQA protocol. They have us pull a sample of 50 cases, and it's just from your entire database. And so many of those are from non-PAR providers because it's the HIE, it's not your delegate data. And it's incredibly hard to get non-PAR charts. You can pay them, you can give them pizza lunches, movie tickets, but they're busy, they kind of tend to ignore you. So I know you may not be on the HEDIS team, but you can start on November 1st of the year before to try and pass the HIE. And I can't stress enough that that's the most important thing there on that slide, because you have to pass by the end of March. So that gives you 2 months in the current year, 3 months, you've got 5 months to pass. So if you've got 15 out of 50 charts that are not from your plan providing part, by the way, you have to pass with 49 or 50 out of 50, right? So if you've got 15 out of your sample of 15 non-PARs and they're not cooperating, you won't pass. You can only be error on one record or one missing record. So it's actually a really big deal. And so you can see why you'd rather them go through the NCQA DAV program. Not that that's easy either. So once you pass, the good news is you probably never have to do that again. Your auditor has to sample it the first year once they pass, unless the HIE tremendously switches up their protocols and processes, you're good to go. So really get the HIE and be really careful in the first year about timing. So now the next silo to break down is paper chart. So how many small offices and individual providers does your plan have with no EHR? Again, can you install some software there? Can you share cost, or what arrangement are you going to make? And if not, if they're non-EHR, through education, can you let them understand if you can't go digital, what are you going to do for me manually? Will you abstract your charts year round and upload them to my portal so that you can keep pace with our data needs? And also, are you going to limit their panel size or possibly close their panel if they can't accommodate your digital needs? So many of our plans are giving some of their providers a heads up about 2 years from now or 3 years from now, this is what we'll do if you don't have an EHR. And then in areas where you don't have significant patient access issues, on a go-forward basis, does it make sense to stop contracting with them if you don't need them for your access standards? So tough world for those without an EHR. So HEDIS provider portals, this isn't fire pushing and pulling of data. This is kind of a practical thing to get the data. So maybe 8 years from now, you won't need this portal, but a provider portal where your providers can log in, see how they're doing on HEDIS, get their gap in cares, and hopefully also upload information on missing services, including possibly the chart, is really about the strongest way to get around the missing data from your providers who are not digital without an EHR. And again, it reduces provider abrasion to have a systematic way to pass the data. So if you're saying, oh, we don't really have a robust provider portal, your IT team can create it. You can purchase the vendors. You definitely need some expert programming. And when you pass your HEDIS gap in care list through the portal, make sure they're at least monthly at a minimum. Otherwise, they're outdated and not so helpful. And if you don't have value-based contracts with your providers, probably pay them to load data to the portal. However, garbage in is garbage out, and the NCQA standard to pass audit for data in a portal is 98%. So if an office has a front office manager entering and they're 94% accurate or 92, you may not pass. So 98% metric comes from, if it's a large database, auditors have to pull a sample of 50. You only pass if 49 or 50 are right, so 98%. So, we pull a sample, so if they're 94%, but we pulled a sample that is on average more accurate, you'll pass, but 98% is the threshold metric. So if they're not value-based and they're giving you data, pay them to encourage them, but don't pay them if the data is not accurate enough to pass or they won't have helped you at all. So race ethnicity, can't talk about it enough because it's coming. So looking at it through a HEDIS lens, expounding upon what Rex was talking. So an accreditation measure for all product lines, that includes Medicare as of MY 2022, which is what you're about to report. So 5 measures are stratified next year. As Rex said, only 3 of those are Medicare, and then more is coming down the pipeline. So important rules here. If you don't have 80% of your data with direct knowledge of race and ethnicity for MY 2023, which is a year later, you're going to have to pay either your vendor or your staff or your HEDIS vendor or another vendor to apply something called an indirect method. So we'll get into those in the next 2 slides. But, and again, MY 2023, 5 or more measures stratified, year after, same number of measures coming in. So here's our definitions, NCQAs. Direct data, the member tells the plans, the state, CMS, another third party, how they self-identify. So direct data sources, surveys, HRAs, disease management registries, case management. So it doesn't have to be on the enrollment form. It doesn't have to be in the CMS or state database. EHRs, your group can pass this data back on to you if they're collecting it. And all the other things bulleted on the slide, plus others. So that's what direct is. They're telling you or somebody else. So what is indirect? That's when you don't know their race and ethnicity and you look at where they live, their geographic data, maybe also their surname, and do a combo. You can do just geographic data alone. I don't know if it's favored upon to do just surname, mix and match. So either your plan will figure it out, you'll buy vendor software, or your HEDIS vendor would do it for you. I'm sure there will be a cost involved from what we've been seeing. So this is complicated. Better to get your data. Plus for the CMS meaningful measures, if you don't get your data, probably won't do as well. So don't like this as a comfortable fallback. It's a bad place to be. So what are these race and ethnicity stratifications? If you're used to reporting HEDIS, it's the same 9 race stratifications and 4 ethnicity is the current diversity measure for race and ethnicity that is, starting MY 2022, a Medicare accreditation measure. So where are plans now? To be honest, these stats are a little lower than accurate because health plans, since they haven't been pushed in this area, not all of them work their best to map their data. So the numbers are actually higher. This is like, what do I have and what am I going to take the time to report accurately? So the numbers are actually higher. This is MY 2020 data. That's the most current available. Again, MY 2021 went final yesterday, so we're going to have to wait a little bit. But who has data on 80% of members or more for race and ethnicity? So you can check where you stand versus that, but clearly commercials lagging behind. So if you are going to gather race ethnicity data on your members, it's really important that you explain why the information is being requested. If you let them know why you're asking for it, it increases response rates. They're less reticent to provide the data, understanding that you've got good intentions in place, and explain how you're going to use the data and the importance of it, so they don't fear that you're profiling them in a way that would not be to their advantage. So make it a win-win for them as you explain in communication why you're asking. And so that takes us through, it's a kind of whirlwind tour of meaningful measures for Medicare and CMS and HEDIS, and I think we have a lot of time to answer any questions if there are any. Wonderful, Brent. come on up and join anything you want to. You are an expert on fire and SQL and where we're going. If you have any more comments, come on up and join the panel.
Well,
Come on up.
yeah, okay, thank you.
You are an expert. Might want to give us some of your expertise. It's hard to find such a fire expert who's arguably the best, so we're very lucky.
Oh, well, thank you so much. You know, first of all, excellent presentation. I got a lot out of it. And I want to talk about something that you guys touched on. It's also something I have seen in other areas, and I call it kind of a pocket mandate. That is, we have been thinking of CMS mandates in kind of traditional terms, sort of all hands on deck moment like HIPAA 5010 or the ICD-10 or switching to the MBIs, where the way that that mandate gets into the organization is through the CMS compliance group. And that way of getting in tends to activate a lot of resources to get the wheels turning, gets it easier to get funding, because everybody recognizes, okay, well, we got to do this. I'm increasingly seeing, particularly through interoperability, what I call pocket mandate. That is, they'll make a technical change and it seems like some obscure change that is affecting only one part of the organization. It's okay, business as usual, you guys handle it. But then I realize that the consequences of this relatively small change may be as big as switching to MBI or HIPAA 5010 or whatever. So you mentioned the SNOMED and LOINC codes. So Rex, when you were at PQA, did they say anything about RX norm?
Not that I recall.
Okay, so on the pharmacy side, for the Part D measures, in fire, they don't use NCPDP codes. They use RX norm codes. And that's another thing that is not present on a pharmacy claim. And you have to have a full interoperability stack to be able to receive that information. Another example of what I call a pocket mandate was in April 2020 when the ONC issued its final rule in the Federal Register around information blocking. And it's a long, tedious slog to go through that whole 350-page information blocking final rule, but there's a lot of really eyebrow-raising stuff in it, one of which is that if you are doing things differently than everybody else does, if there is an emerging standard, either an explicit one or a de facto standard that has emerged, and if you are not doing that and everyone else is, that's information blocking, and you can be heavily fined. So this is the kind of thing I'm talking about when I say that we're probably going to see more of these kinds of pocket mandates that are really being driven by obscure technical changes rather than, you know, being up front and saying, oh, this is a mandate, you have to switch over to here by such and so time. So anyway, I just want to kind of raise visibility on that this is very typical of what I think we're going to be seeing.
And I also wanted to ask you yesterday, we were talking about information blocking. One of the problems with HEDIS is you often have 7 days or 30 days to do something on some of the hard measures like follow-up. So if you just need it for the year, it would seem if they changed information blocking rules, yes, after a year is an egregious flagrance of the law. But if somebody's blocking you on information you need so timely and so quickly for 7 or 30 days, I don't know that they're going to be able to help enough at this point.
Yeah, they probably wouldn't. And the reason is because the way the information blocking is set up, you have a certain grace period before you absolutely have to comply with that. And it's going to be impossible to use information blocking unless perhaps there's a repeating pattern of it to say, we keep seeing this problem from this one source. In information blocking, there are 8 exceptions, and one of them is a feasibility exception So anyway, it gets, I mean, the information blocking rules are very complicated, but I think the short answer is they're not going to be able to help you much.
Yeah.
But
But it's a good prong for leverage.
yes.
Thank you, Brent.
Any other questions?
Hi, my question is about HIE, and you said that you could start the audit on 11/1 of the measurement year. If you do start that on 11/1, does that mean you have to stop all non-standard supplemental data collection at that time, or can you just specifically do HIE and still collect non-standard?
That is
Rest of
such a
your-
brilliant targeted question. So first, panoramic-wise, each of your supplemental databases goes through separately when you're ready or when you have to be ready. So if you do HIE, if you have 3 HIEs, you can send them at different times. So okay, so for non-standard HEDIS data, you may not start the audit till you have 100% of the data. And once you say you do, you can't add to it unless your auditor is willing to go, okay, I passed it, but we'll just pretend that didn't happen. Add more, it's still in time, it's not middle of March yet. We'll do it again. So for EHR and HIE, NCQA doesn't define how large the slice has to be. Since we have to pull a sample of 50, if you had 2 weeks or 4 weeks or 3 weeks, not even a quarter or a third of a year, as far as we're concerned, there's no written rule, we'd go forward. So, if an HIE can say to you, all right, I can't give you the whole year, plus it's 11/1, why would I? If they give you the month of February, even if you're trying to go through in November, you're gonna be okay, that's an allowed slice. And so if you usually, you wouldn't have the whole year, but you might not have a lot of data. If you just say, look, it's July, we're working on this for next year. Can I have at least 500 cases by November 1st? If you get that, your auditor should say, fine, it's a representative sample, let's go through. And then you've got those 5 months for any non-par to say, I need that chart, I need that chart. Or the other thing I didn't mention, because we're going quickly, there is no limit on the number of times you can try to pass. Your auditor firm might get mad, but we don't charge extra, but I can imagine saying, this is your 5th time, I need to charge you at this point. But if you take a sample in 50 on November 1st, and by December 15 say, I don't think I can swing this, the auditor pulls a second sample, no penalty, you try again and again. And I would never recommend gaming the sample, but if you had 20 that were non-pars, if you want to give up after 2 weeks and see if the next sample might be 15, more doable. So you get multiple tries to pass. It's not like California, 2 strikes, you're out, or 3 strikes. You can keep trying. You only have to pass by the deadline. So that's the strike, if you miss the deadline of the end of March. So start November 1st. If you can't pass the first sample, maybe you got one non-par group that's just really uncooperative. They say, you talk to SciAx, and SciAx is 3 months. Well, that's not going to work. Let's move to the next one. We did have a COVID exception, and I think it's gone, but when COVID first kicked around, NCQA made a relaxment, and they said, if a group will say, I won't give you the chart due to COVID, you can take it out of the sample or replace it. We still have COVID. I mean, some of us have masks. We're all boosted, I'm sure. It's not in the rule book, but you could kind of push for it a little, maybe if you're close to 50, right? But honestly, I'm talking across all firms. We've passed all HIEs we've gotten, but we're type A to help our clients. Like auditors kind of sit back and go, you do what you want, but here are the rules. So I do think over half have failed just because they couldn't get the non-par charts and didn't start on 11/1. So if your audit firm's not being proactive and pushing you in a type A way just to help, you can run out of time. And honestly, we play by the rules, but we told a couple of our clients who were about to do it and said they didn't want to do it that year. We said, well, you've got this COVID relaxment right now. Go for it now. It'll be a lot easier. And we followed the rules, but I think that was good coaching. So yeah, really important to get them in. And if you try for 3 and get 2 in this year, the next year you'll probably get the 3rd. So we haven't failed any, but I think that overall the national fail rate's over 50% just because of the timing. And that's another reason to say, the HIEs will charge you anyway. Go pay NCQA and do the data aggregator validation program and we'll never have to worry. The only problem there is they have to pay yearly, but they're charging you, I think it makes it easier. It's a little more expensive, but I think it makes it easier. So number one, really encourage them to go through the NCQA program, and if they won't, you need some data by 11/1. Yeah.
Thank you.
I think we're a little over. Yeah. So thank you so much, Catherine. Great information. That was so good, thanks. Okay, next sessions, and thanks so much, Catherine, really, really valuable information. We're gonna go to NLP, so closing gaps in care through provider portals using NLP. We have Sarah Winsky, the Director of Clinical Quality Services for HEDIS at Gateway Health, and we have Grant Roholt from Novellus, and you guys can feel free to do a little bit more introduction if you want to. Thanks so much. Yeah, it's a forward, backward, and laser. Okay.
Good morning. So my name is Sarah Winsky. I'm the Director of HEDIS for formerly Gateway Health Plan, now Highmark Whole Care. And
I'm Grant Roholt. I'm the Chief Technology Officer and Solutions Architect for Novellus.
awesome. So we're going to talk a little bit today about a project that we launched last year. We called Quality Acceleration. So as a company last year, we made a decision that we really had to push forward with our quality scores. Things that we'd been working on for a long time, but really got some resources dedicated behind it to make it a large initiative throughout the company to increase our performance to one of the top 3 MCOs within the state. So obviously that's not something that just happens overnight, but we deployed a large set of initiatives across a variety of different areas to really push that performance forward. And looking for increased performance for multiple reasons, obviously, to improve the quality of care to our members, but also in an increasingly competitive market within the state for our Medicaid contracts, to improve our performance, to improve our likelihood of winning contracts going forward, as well as increasing payout for our pay-for-performance programs. So again, this did not happen in a silo. There was a lot of resources and people brought to the table to move the project forward. And there were a variety of different areas that we focused on. One being the increase in data and increasing the quality of the data that we're getting as well. So that's really where we're going to focus today, talking about the project that we launched with Novellus. But there were a variety of other areas that we focused on as well, including really working with our providers and engaging them in new and different ways to increase their likelihood to send us the information that we needed, as well as reaching members that were unreachable, members that we couldn't find, members that were not involved with our PCPs, to really get them re-engaged in care. So this was fast. We really started talking about this at the end of summer and then launched in the 4th quarter of last year. So it was a very fast project that we moved forward with the help of Novellus, and really had a short amount of time to make an impact for this year's HEDIS season. So we really collected data primarily for the last 3 months of last year, and then, as we'll talk about later, moving the program forward into this year. But it was a very fast, hit it hard, and squeeze out what we can by the end of the year.
Thanks, Sarah. Yeah, I'll underscore fast. It was a lot of fun. Sarah's team and the entire team at Highmark Whole Care is just fantastic to work with, and that's part of the success. Yes, we have a solution, but they're very willing and able partners, so it was really a fun project to work on, and she'll tell you more about the outcomes of that. But we do offer a comprehensive care gap management solution. It does have a portal as part of it. And so what you'll see through the presentation is we take in member rosters, so the latest list of members that are attributed to each PCP, We got that from Gateway. We put it in our system along with all the gaps in care that are open, or in some cases they're closed, but you're looking for that last reading of the year. We also couple to the solution an experience for the practice managers and providers that not only shows them their list of member rosters and care gaps, but they can see their incentive progress year to date for the incentive plan or plans that are in place for the health plan. And how are they tracking on earnings? You'll hear about NLP, that's a branch of artificial intelligence or AI. We track everything. We have an omni-channel customer relationship management solution that's behind the scenes. I come from a marketing services background, and so like any recovering marketer, I want to know what is happening as a result of the outreach actions. So Novelis is got a lot of skill in provider engagement. So what that means to us and to clients like Sarah is we know how to get busy people to do what the plan wants them to do. So just having a portal alone, we see doesn't get the job done. You have to figure out how to motivate them. And I love Shannon's presentation yesterday. If I have feedback for the conference, I would love to hear more about her because she gets into the psychology of people and motivating them. And I'm definitely in tune with that. They're very busy people. You have to figure out how to get them to do what the health plan wants to take better care of the membership. That's easy to say, hard to do, but we've got a lot of skills in that area. So we use multiple channels of engagement that don't cause provider abrasion to achieve that. So it all starts out typically with in the rhythm that the provider practice managers get used to. They get an email every week that tells them what are a list of open care gaps, whether that's Medicare, Medicaid. It can display the incentive progress year to date. We either calculate for the plans or the plans send it to us pre-calculated. And then a really simple, clear call to action, view progress. And they go right into the provider portal and they can see at a glance what are the list of care gaps for their practice. And they have an at a glance gap closure progress screen on the right that keeps them apprised across various gap types. What is their gap closure progress and how are they tracking year to date? So we handle both risk adjustable and quality gaps. And you can see that displayed there. And then as they look at each member's panel, they can see, for example, I'm showing here a comprehensive diabetes care, blood pressure controlled care gap. This is the practice manager experience. They can click on that, submit the evidence that will satisfy gap closure rules, including the chart, systolic, diastolic, data service type of service. And they can drill down on each measure to see their numerator and denominator performance, and right integrated into it, they can see the estimated incentive earnings that this particular measure contributes to their overall earnings. Now I'm going to talk just briefly and then about the NLP component of our comprehensive solution. I'll turn it back to Sarah to talk about program results and take us out. So as Sarah put in the summary of this presentation, being good at closing care gaps requires getting chart data and data through a number of channels. One of them is a provider portal. You saw how they can submit medical charts this way. But another is through chart chasing. And Sarah's team presented us back in late summer when you came to us with a challenge. And these are going to be familiar challenges to many of you, if not all of you. Really good news is they obtained thousands of charts through a chart chase process. Well, now what do you do with those charts, right? You got to process them. And Sarah's trying to do more with less. She has a really great team, but she has limited staff, right? It's a great team, but it's hard to get budget to get that staff added to do the time-consuming abstraction process. And the charts can vary from 1 or 2 pages to 1,000 pages, right? You can get the chart chasers just coming back with the entire longitudinal health record of a patient. So that's really hard to do, as many of you know. And then there's just a relentless schedule pressure, right? It's just omnipresent. So this is what we did to help with that process. So I mentioned we got the charts, or actually Sarah's team got the charts through the chart chase process, tens of thousands. They give it to us in a bulk transfer process. And we have all the care gaps set up in our system. We know all the rules. And then we use our natural language processing to do clinical reasoning on each of those charts. For example, colorectal cancer screening. In the chart, our NLP reasons, is there a date of service present? Is that really a date of service, or is it the date the chart was produced? You know, that not all dates are equal. What was the valid type of service? Was it a colonoscopy, an FOBT? Is it a physician that did the encounter, or was it a DO? We reason all of that, our robots do that. And then we present to Sarah's team in a simple summary, what are the results of our NLP findings? Was all the evidence present, or was some of it absent? And then very quickly, her team was able to take those results, the NLP findings, and then decide whether to accept, everything's present, looks good, or reject those submissions. And they would all show up in a workflow, a real-time workflow queue as they were being processed. So it significantly decreased the time for Sarah's team to review these charts, which could vary from a lot of different page sizes I mentioned. And then lastly, we would take these accepted submissions that Sarah's team accepted, and we would pass them back to Highmark Whole Care's sources of gap truth. That was a lot. So I like kind of the Discovery Channel view of things. Here's sort of a cartoonish view of things that animates. So here's the chart chase process. All the charts came in. Sarah's team got them. They sent them to us. You're not supposed to laugh, Sarah. This is really the cool part of the show, man. I worked really hard on these animations.
You're awesome.
Thank you. But NLP processed them and serves them up really on a silver platter for the Highmark team. And so they would use this interface I spoke of, and they would either accept or reject those submissions. And when the accepted ones would go back along with the charts to Highmark Whole Care, and they would be ingested into their HEDIS engine. So that was the chart chase bulk processing lift that we gave to Sarah's team. But you recall just a few moments ago, I showed you the provider facing portal. And so, as was mentioned in the previous presentation, we really feel that a provider portal coupled with some engagement expertise is necessary, certainly for the next foreseeable years while interoperability is coming. And so in that provider interface, I mentioned that we get the member roster and the care gaps from Highmark Whole Care. We put them into our user experience that is very simple and easy to use for the providers. And the practice managers submit evidence against those care gaps. They come back into our system. NLP does basically jump in front of the validation process. The same logic gets applied to the provider submitted charts, not through a chart chase. And then the abstractors use the same interface to accept or reject these submissions. And then, just like they do in the bulk process, they go right back to Highmark's sources of gap truth, which is the HEDIS engine. So now I'm going to turn it back over to Sarah, and she's going to take us out and talk about the project results.
Thanks. So we were overwhelmed by the response from our providers with the CGMA application, the provider portal application last year. We had over 12,000 submissions through the provider workflow management tool. And that's just from October to December. And we only launched it with providers that were already using Nobilis's system at the time. We had previously had an internal application that was built to do similar functions where providers could send in charts. But the response was so much greater using Novillis's portal. We had over 4 times the number of submissions come through, so the acceptance was much higher, and definitely an increase in the provider satisfaction through using it. For the NLP project, we processed over 20,000 charts through their NLP software in that last quarter of the year, which again, without the increased efficiency from the system, we would have never been able to get through that volume of charts. Definitely increased the number of charts that our nurse reviewers could review each day, and really helped to weed through some of those enormous charts that we would get through the door from some of our providers. So it really allowed us to expand the number of charts that we could do and the number of gaps we could close during the time we had without expanding our staff. So impact on our rates by measure. These are some of our, I guess I'd say, biggest success stories for last year and for our Medicaid and Medicare lines of business. You can see we did chart collection both on hybrid measures as well as on admin measures, and even tried some measures that we'd never done prospective chart collection on before. So it's always a challenge with prospective chart collection. It's a timing thing, right? So you're requesting charts for services that may have just recently happened, and maybe a claim is on its way in that would close that gap, but it's hard to know those sorts of things. So we certainly abstracted more information than you see in the rates, but again, it's a timing issue, and we were super pleased with our impact on some of our measures, and definitely, excited to see that grow as we move forward. Again, very positive feedback from our providers that the system was easy to use. It was really quick, and the adoption was easy and painless for them. And Novillis has been great partners with getting providers up and launched on the system and getting them using it in a very seamless manner. So as we move forward into this year, we're making some expansions and some improvements. So our CGMA application, the portal to the providers, launched in April of this year. And as of the beginning of June, we've recorded over almost 3,000 submissions through CGMA, and excited to see that grow and increase as time goes on. We've expanded the member roster that we send to Novillis each month to include all of our Medicaid and Medicare members instead of just a targeted group as we launched last year, and also expanded the measures that we're looking at this year. So this is the list of additional measures that we're looking at for this year to try to get gap closure back on. And then for NLP, we're trying to figure out our sweet spot. So we certainly want our providers to be engaged in the CGMA application and sending charts through there. And it's a easier process for them and for us than us collecting the records on our own. But not all providers are currently engaged in that. So we're looking to identify providers that are interested in engaging with us, but not currently engaged in the CGMA application, where we'd be willing to assist them in pulling the information out of the charts and then processing it through the NLP application. And we'll be launching that here in the summer as we've finished out our HEDIS work. That's our plans for this year.
Any questions?
Yes, Dan, you in the back.
Don't answer this.
So for the, just quickly, so you send members roster and you also send gaps over to them?
That's correct, yes.
Okay, and in regards to NLP, you showed us the pass rate, like 3%, 5% additional things were picked up by NLP. Were there any instances when NLP missed the things?
That's something we're actually going to try to look at this year. So again, last year as we launched really late in the year, we were hitting it hard and fast and really just trying to squeeze what we could out of it. That's something we would definitely want to look at for this year. I know Novelis has been great partners in enhancing it as well. And, really interested in that feedback about where are we seeing things maybe slide through that are not getting caught. But that's definitely something we want to take a finer lens to this year to look at. Again, how do we work smarter and faster, right? And make sure that we're capturing as much as we can out of those charts.
Sounds good, thank you. And one more question, oh gosh, I'm slipping my mind. And so the documents or charts we were talking about for NLP abstraction, are those EMR Claire charts? Are those paper charts? Are those faxed EMR charts?
They're a little bit of everything. We sent them the whole kitchen sink. So certainly the majority of them, I would say, are probably either electronically downloaded or printouts from EHRs that providers sent in. We do have some volume of, I guess I would say, a traditional medical record, right, where it's a doctor's handwriting and things like that. But the vast majority of our charts are either EHR downloads or printouts from an EHR.
Okay, sounds good, thank you.
Thanks, Rex. So, interesting question for you guys, just knowing a little bit about what I know about it. Did you see any advantage within the relationship for the providers that leveraged the tool but maybe didn't want to very actively participate in your chart chase efforts?
I think we definitely saw providers that didn't want us coming into the office to collect records, being willing to submit charts through the application instead. Not that they wouldn't participate in our chart chase in the past, but they preferred this method. It was more seamless for them, and they weren't having to fax things over, and certainly weren't having to let us in the office, especially in the COVID world where we're living.
Yeah, and one comment I'll add just in closing is we see this pattern all the time where chase charts, process them, in addition to having the care gap management solution. But as you get into year 2, they see the value of the care gap management system. And so it sort of, decreases the need for chart chase because it's just a better experience. And so we'll see that kind of sliding down pretty quickly, I think, in the future.
Did you have any experience with offices that use like a third-party vendor, like SciOx, MRO, ShareCare, anything like that? And did you have any roadblocks with that? Did they submit for the charts to you, or did you still have to go through the third-party vendor?
We did go through the third-party vendor for those. And just historically, we've sort of, it's a complicated relationship with those third-party vendors. We've definitely had some years more success than others in getting them to engage in the project, but it was actually an area where we found some challenges in processing the charts through NLP because of some of the additional pages that they tend to attach at the beginning of a chart. So that's something that we had to work through, and because it was sort of mucking up the NLP process. So something we worked through for last year, and again, had varying success depending on the vendor.
Yeah, we would, to amplify that just a bit, is we would see, and I won't name the vendor, but a vendor would submit a chart that wasn't really a chart. It was, I looked, I didn't find anything, and here's the invoice. Hi, Mark. So that was fun. But these are the things we encounter, and we keep adapting the system so that we overcame that with Sarah's team, and she and I are working together. So next year, she's, for the chart chase that we're going to do, she's gonna work with those vendors to be better partners in the whole supply chain, right? Help us, help everybody, and then help the member by doing a better job of submitting actual value and not just an invoice for nothing found.
One more?
So do you have any capability to directly tap into specific EMR systems as opposed to working off of the PDF files?
Come talk to me later. You probably saw Brent Zenobia. I hope you saw Brent Zenobia's FHI, or an interoperability presentation, and I'll tell you about our roadmap. Short answer is
Thank you.
coming.
That's it. Any last questions? Okay, thanks so much, Sarah and Grant. Okay, in one more session before heading to break, the role of a clinical pharmacist in Medicare Stars, Lynn de Guzman, Regional Clinical Operations Manager from Kaiser. Is Lynn here? Oh, Lynn, this is the virtual session, right, Audrey? I think this is a pre-recorded virtual session, right? Okay, okay. So it's again, the role of a clinical pharmacist in Medicare Stars, Lynn de Guzman, Regional Clinical Operations Manager, Kaiser Permanente, Northern California.
Kaiser Permanente as a Clinical Pharmacy Services Director for National Pharmacy. Today I'm going to share with you the role of the clinical pharmacist in Medicare Stars. So today I'm just going to give some background information, talk about Medicare Part D, Medication Therapy Management, also known as MTM. And also deprescribing polypharmacy and medication adherence. So hopefully with this aspects, you can see the value of having clinical pharmacists involved in Medicare Stars. Hi, good morning, everyone. Thank you for listening in on my presentation. My name is Dr. Lynn de Guzman. I'm a pharmacist at Kaiser Permanente as a Clinical Pharmacy Services Director for National Pharmacy. Today, I'm going to share with you the role of a clinical pharmacist in Medicare Stars. So today, I'm just going to give some background information, talk about Medicare Part D, Medication Therapy Management, also known as MTM, and also deprescribing polypharmacy and medication adherence. So hopefully with this aspects, you can see the value of having clinical pharmacists involved in Medicare Stars. Just to provide some background information, there are so many opportunities for pharmacists to be involved, especially with Medicare Stars. This is just a list of all the clinical Part D star rating measures, with an exception of the MTM program completion rate. That's actually in the administrative measures for Medicare Stars, but a lot of opportunities with medications. Also sharing more opportunities, we have the star ratings display measures. So historically, a lot of these measures eventually become star rating measures. And again, it involves opioids and a lot of polypharmacy deprescribing opportunities. And even looking beyond Medicare Stars, there's several HEDIS measures that also includes opioid and cardiovascular risk measures. But as also you could see, there's opportunities in COPD, asthma medications, and even antidepressant. So medication adherence. Studies have shown that patients taking their statin, blood pressure, and their diabetes medication regularly are able to have there's a reduction of total healthcare costs and an improvement in hospital readmission and utilization rates in an emergency room. So definitely taking your medications regularly will help keep our members safe. So it's just an opportunity for our pharmacists who are the medication experts to help in this. So I'm going to start with our journey. We first started here with Medicare Part D Medication Therapy Management Program. So at Kaiser Permanente, our pharmacists are working under collaborative practice agreements. They are also residency trained or have clinical pharmacy equivalent experience. So with that, what is MTM? So it is part of the patient's Medicare Part D benefit. It's required by law through the Medicare Modernization Act. CMS requires that MTM services are provided to a subset of high-risk Medicare patients. And these high-risk Medicare patients are identified through the health plan, and it varies. But across the country, the average is around 10% of Medicare members are identified as high-risk, meaning also MTM eligible. CMS has said that the goal of MTM is to ensure that covered Part D meds are appropriately used to optimize therapeutic outcomes and designed to reduce the risk of adverse events, including adverse drug interactions. Some further background information why MTM was developed by CMS is that admissions were related to medication use and was increased by 52%. Medication events post-discharge around 20%, and a high utilization of hospital readmissions and healthcare costs with our Medicare beneficiaries. So MTM was a way of really trying to help with decreasing total healthcare costs and adverse events related to medicine. So what is the eligibility criteria of MTM? So CMS does set these regulations. So our MTM patients have these three criteria. They have multiple chronic conditions, they take multiple Part D drugs, and also have a total annual drug cost spent of around $4,000. The third amount, the $4,000, varies every year, and in 2023, it's $4,044. At Kaiser, our Medicare members have at least 3 chronic conditions and take 5 Part D drugs. So what services does MTM provide? As a requirement, MTM needs to provide an annual comprehensive medication review. And that, the title says it all. So our pharmacists really review the medications carefully with our members. They make sure that the instructions are correct, that they're taking it as prescribed, understand why they're taking it, make sure there's no drug-drug interactions, ensure that that also the over-the-counter medications are taken into account. Ask the member, why they're taking it, kind of have a back and forth discussion to make sure that the member understands why they're taking their medicines. And if we do find anything that does cause for alarm in terms of drug-drug interactions or any even drugs to avoid in the elderly, if we see any high-risk medication being ordered, under collaborative practice agreement, our pharmacist is able to discontinue a medication, start a medication, or even titrate therapy. And that's where the targeted medication reviews come in. CMS requires quarterly targeted medication reviews. We utilize this opportunity to schedule follow-ups with our members. So if we make a medication change or assess that they need help with taking their medications to improve adherence, our pharmacists will schedule follow-up appointments with the members to make sure they're doing okay with any of the medication changes or that they're taking their medications as prescribed. So here at Kaiser, we definitely showed a lot of value of MTM for our members. We've shown that patients who have had an MTM service, 88% of them are less likely to fill a drug to avoid in the elderly. And these are medications that's listed in the Beers criteria for patients over 65 taking these medications. It may increase their risk for falls. So really grateful that we were able to get our members and have them safe. We've also shown that patients who've had an MTM service had a reduction rate of mortality and even a lower odds of hospitalization. And internal data has shown that our Medicare members, or at least the MTM Medicare members, have improved their adherence compared to outside of our MTM space. So in the high 90s. So really a value to the service. Because given the work that we've done in MTM and shown all these great value over time, we started to ask, our partners within our integrated healthcare system started to ask us how we can expand our service to include Medicare members within the medication adherence space. In this work, we were able to really expand our patient reach to include patients who take oral diabetes medications, statin, and RAS medications. We developed predictive analytics internal reports, which would predict patients who would be at risk for being non-adherent by the end of the year. So utilizing these patient lists and really identifying these members, we definitely started to outreach our members. We have mandatory consults at the pharmacy. So if a patient comes in just to pick up an antibiotic, and then there's an alert in the system that shows that they could be non-adherent taking either one of those three drug classes, the statin, diabetes, or RAS, a pharmacist will speak to the member one-on-one to just educate them more, find out any barriers, or provide solutions of getting their medications filled. We also incorporated live outreach calls to really talk to our members to really help them with their medications. And we're definitely leveraging technology, having interactive two-way text messaging and sending kp.org email messages. And these are secure messages where our patient has to log in to their Kaiser account and to read these messages. So it's more personable in that sense, knowing that we are working collaboratively with our physicians. Our key team message when we're making these calls is our mission is to help our members understand the importance of taking their medications daily, identifying barriers, and providing solutions. We're really not a refill reminder service. Our service is really to empower our members. And we really try to identify if we have to call a member twice, we need to have a deeper look to find out what do they need so that they can remember to take their medications on their own and knowing the importance of taking it every day and as prescribed. So soon as we started in our MTM arena, really doing comprehensive medication reviews, as I mentioned earlier, we had opportunities in stopping the drugs to avoid in the elderly to improve, to decrease their risk for falls, and then also helping our members with taking their medications. We soon went into the deprescribing arena, really addressing polypharmacy with our members. So as our reach started with our MTM Medicare patients and expanded out to Medicare patients taking diabetes, medications, statins, and RAS, now we're even expanding our scope to look at members taking multiple medications. So polypharmacy is taking 5 or more medications. Studies have shown that polypharmacy can increase the risk for hospitalization, especially in the elderly. And we've, of course, noted hypoglycemia can lead to falls, cognitive decline, and death. So we found some opportunities in our diabetes arena. a lot of studies have been shown and the evidence that a lot of patients are going into the hospital by taking too much medication of their diabetes medication. So again, another opportunity for our team to really address this. And then over time, as you can see with the census population of age 65 and over, we're going to see an increase of those patients. And with that, they're going to be taking more medications. So it's really time for us to kind of take a second look to make sure that they're taking their medications appropriately and maybe looking at opportunities to see if we can help simplify their medication regimen. The World Health Organization also, put medication without harm as a global patient safety challenge. And who better to really ask, to solve this is the pharmacist, right? Who are our medication experts? So really incorporating your pharmacist into your healthcare team and partnering them, with the physician-pharmacist collaboration will really help solve this global patient safety challenge that the World Health Organization has asked all of us to solve. So what is deprescribing? It is a planned and supervised process of dose reduction or stopping of medications that may cause harm or are no longer beneficial. So what we did here in our organization, again, utilizing our MTM pharmacists who have been doing this work for years and started to go into the adherence space and moving them into the deprescribing space. So we really just replicated our MTM program and then expanded our reach. So we did work with our physicians, again, very closely, to identify patients who would be great candidates for deprescribing. So this is our deprescribing criteria that we looked at, really trying to identify those patients that would benefit to, whether reducing their dose or stopping their medication. And what we did was found great results. So for the patients that were able to deprescribe, we saw a decreased rate of hypoglycemia, and we did not increase the rate of hyperglycemia. We also noticed no significant changes in their A1C control. So our members that we did stop the med or reduce the dose, they were still at goal with their hemoglobin A1C. We also have demonstrated they may have survival benefits within 12 months. So really showing that the work that we're doing in this space is really making a difference. We are looking at opportunities of expanding it to other disease states. Also, just an aside, we also noticed that when the patients that we did deprescribe, we saw an improvement, at least anecdotally, with their statin adherence. And I think that is due to really just helping simplify their medication regimen so that they can remember to take the other medications that's really important within their medication regimen therapy. So as we are doing all this work, again, our journey from MTM to medication adherence to deprescribing, we're finding a lot of great opportunities in health equity. And what we're using in health equity is using the CMS framework for health equity priorities. So you can find this on the CMS website. And we are actually using kind of these 5 priorities to really identify opportunities. So for priorities 1 and 2, we are looking at the data, really kind of drill down by patient population to see what the adherence scores are of our members. And we are seeing that disparity. We're seeing disparities of adherence between our African American, Asian American, Hawaiian, a Native Hawaiian, and our white population. So with those disparities that we did see, how can we help address that? So we are looking at predictive analytics, really trying to identify social health risk scores, which members may need help in terms of identifying social determinants of health, really partnering with other stakeholders within our organization, such as our community benefits, our social health organization, to see how we can, help triage our members who may need community resources to help them. And once they get the help with community resources, then that will also in turn help them with remembering to take the medications that they need. And then for priority 4 and 5, again, how do we also tailor some trainings for our staff to help, with culturally tailored services. And again, that's really with the partnership that we're having with our stakeholders outside of our pharmacy department. So it's been a wonderful journey, really trying to use this framework to help our members take their medications. And hopefully in another presentation, I'll have more to share. So another opportunity to really integrate pharmacists into this work. So let's talk next steps. But before I go there, I just wanted to share just our clinical pharmacy communication journey, as I've mentioned earlier. Again, really starting in the Medicare Part D MTM space, as CMS has made this part of our members' Part D benefit. Really leverage this opportunity to use our pharmacists to help our patients understand their complex medication regimens. I didn't mention too, a lot of our Medicare Part D MTM patients take an average of 10 to 15 medications. So really trying to help them remember to take them, understand why it's important, and making sure they're taking it correctly and to reduce any adverse event was really important. To do that, we started, our staff really got engaged in motivational interview training. So we had live classes that were offered at our organization to help with our pharmacists so that they can start motivating our patients to take care of their health. Soon as we moved into the medication adherence space, we maximize the Bristol-Myers Squibb Real Connections patient engagement training. The Real Connections was actually developed geared towards oncology patients. However, we saw value in that to use in our medication adherence space. So our pharmacists got additional training just to see how they can continue engaging our members. And soon as we got into deprescribing, we identified ways that we needed to incorporate behavioral science techniques. One technique that we used was the peak effect, or the next step effect, meaning that, congratulations, you have done a great job in taking your medications regularly to keep your A1C at goal. I think it's time for us to go to the next step, the next phase, and let's talk about that. And so just starting our conversations utilizing that behavioral science technique really engage our members to be open to stopping their medication and reducing the dose. We also wanted to empower our members, so we definitely maximize the AHRQ, shared decision-making tools. Really trying to, again, we trained our pharmacists using the AHRQ website on their shared decision-making, trying to make sure that when we are stopping our med or reducing the dose or helping our patients understand the medication, that it's a shared process in working collaboratively with our physician and our member. And soon, as we're getting into the health equity space, we're finding a lot of opportunities to really engage our pharmacists to have social health conversations, really trying to hear the trigger words to help identify social determinants of health. So if we're hearing words that, I lost my job recently, or, it's really hard for me to pay for my medications, I need to pay for rent or for food, we are really trying to get our pharmacists to really listen in and hone in on those words, and also finding opportunities to triage our members to our community benefits team so that they can connect them with their local community resources to help really empower our member and with this to help with the social health concerns. So really, what an exciting journey that we've been involved with, and really the pharmacist has played a key role in really having these conversations with our members to understand more, and in partnership with our physician, really helping our physicians kind of take that extra step in terms of understanding their medication therapy. So our learnings, as you've heard me say, really find your clinical champions. We have such a strong physician leader in Kaiser, and really, promoting pharmacy services, really partnering, working together to develop guidelines, identifying members that have the highest opportunity for medication intervention, and of course maintaining strong communication, regularly updating your team members, get them engaged once new guidelines or clinical practice recommendations are made. How can we actively continuing our partnership to improve on that work? Also for system learnings, and I would definitely encourage you to really encourage your pharmacists and physician to collaborate right from the beginning, really to create standard documentation workflows. This way, the physician can read our note, understand what they're looking for, help our pharmacists ensure that the communication is concise and brief to help our physician know that we are working with their member. Also set up a performance improvement foundation. We partnered with the Institute of Healthcare Improvement and applied a lot of performance improvement principles in our work. We would do small tests of change and have PDSA cycles and just start with 5 members. And from those 5 members, we would start with scripting, what trigger words to listen to, and then improve upon that and start to double that, and then continue doing that as we build a guidebook or a playbook to help see what is the best way to help our members. And then how do you keep this information in a central location so everyone can see it within your organization? So we've definitely leveraged SharePoint to put our resources, literature, and data in one central location so all our partners and stakeholders can see what we're up to. And then, of course, identify key meetings to attend. I think when we first started this work, we were meeting monthly, and then it moved to quarterly, and now it's biannually. Really, just to let all our partners, physicians, pharmacists, leaders, know what's been happening, where we may need their support, what things should we change, what other new updates have happened. And as I showed you earlier in the slides in the beginning, really consider quality metrics. There's a lot of opportunities with our medication-related quality metrics that the pharmacists can really help drive change and improve on those measures. And of course, just some leadership learnings. Just live and breathe and start with your pharmacist partner. Really want to empower you to reach out to your pharmacist to find out how you can start active collaborations and partnerships with them to help our members with their medication. And I definitely want to encourage you to also advocate for your pharmacist. Currently, CMS does not recognize pharmacists as a provider. So really sharing the value of the pharmacist as a key partner, a key team member in the healthcare team for our members to help them with their medications. And as you've seen, we've been publishing our work. So I want to encourage you to publish your work as well and share your story so that it can motivate and inspire these future partnerships to help our members. And of course, just start. Hopefully by coming here today, that's just the beginning. Sorry I can't be there in person today, but I'm really grateful for you to take the time to listen to my presentation. I encourage you to please email me any questions or even feedback. I'm always willing to learn what you're doing at your organization in utilizing your pharmacist. And there's my email written below. So thank you so much for taking the time to listen to my presentation and enjoy the rest of your day. Take care. Thank you.
Okay, thanks, Lynn. All right, we're gonna go to break, 30 minutes, come back at it's 11:05, and then we have 3 final sessions before we end, okay? Thanks, everyone. And refreshments next door. Good. Okay, I think we're gonna bring it home. So three short sessions, 3 30-minute sessions, and this next one is provider incentive programs and value-based care to drive health outcomes. And we have Francie Shelton, Program Manager of Medicare Quality Incentive Program at Cambia Health Solutions. So Francie, welcome.
Well, thank you to everybody who's still here and didn't have to take an early flight today or get home last night. You know, I wish that Melissa was still here because I wanted to tell her about how she's inspired me by telling us that, you know, we're all the partners in innovation now with CMS. And I was thinking if we all had walk-up music, you know, we'd come up here and we'd need like the theme to Rocky. You know, I feel like, you know, I have a big joke that this is my first job on the dark side. You know, I've never been with a payer. I've been in healthcare for 15 years, but this is my first opportunity to see how amazing, you know, all the work is that everybody's been doing. So I've really enjoyed being here for the last 2 days, and I really admire all of you all. And then I was thinking the other thing that could be our theme song is what doesn't kill you makes you stronger, right? Because you know, when I hear about this is the most change that we've ever had in STARS, you know, and we're being asked to pivot, you know, even more and faster than ever before. So really commend y'all for what you've been doing. And so what I'm going to talk about here today is what we do in the provider space to incentivize providers to take action, you know, that we all would like them to take. And so we've had a lot about human motivation, you know, over the last couple of days, and that's what we're all here to do. And so that's kind of what I'm going to be talking about is our program of how we try to incentivize our providers to you know, close gaps in care and do all those sorts of things that are going to help us achieve those good star ratings. So yeah, just going to go through who we are, what our vision is, tell you about our program, the impact that I think that we've made, and then tell you a little bit how we're going to look to the future and the things that we want to change and the exciting things, you know, that we want to do as we go forward, and hopefully leave you some time for questions. Or if you want to jump in at any time, please feel free to do that. I am curious if anyone here, it doesn't seem like it as we've been going through the presentations, but does anybody here actually work in your organization for a quality incentive program, or do you all have them? Do you all have programs where I see heads nodding, so that's good, yeah. I'm curious what y'all are doing. So like I said, if you have questions and you want to make this more of an interaction, please do. So just as we go through this, in case you're wanting to kind of compare yourselves to who we are, you know, and the size of our program and that sort of thing, we do operate 5 health plans in 4 different states. And the way that we run our program currently is we pay at the tax identification level. So we're working with 1,371 TINs, and we're currently covering a little over 100,000 attributed members. And I'm speaking today, you know, just of our Medicare quality incentive program. And so just on a day-to-day basis, if you're wondering how we're accomplishing this, we have a 4-member team that we operate with. And so we have a director who works kind of at the higher strategic level, making those types of decisions. And then I'm the program manager. So I'm managing more of the day-to-day and trying to decide maybe what we should do next year. And currently, you know, trying to get our last year's program paid out, that sort of thing. And then we have a project coordinator who helps us answer questions, helps us with documentation, those sorts of things. And then finally, we have what we call a process improvement consultant, and he kind of acts more as our project manager throughout the year, keeping things on track. And then, of course, we could not be running a program of this size really with 4 people. So we have all those other folks there on the slide that are supporting us, as well as our portal vendor who you heard from this morning. And so we do work with Novillis as well. So this is just here. This is kind of what we put in our marketing materials, and this is the vision that we have for our program and why do we do these incentives. And so I went out and talked to several of our subject matter experts at the company, and I said, you know, why do we do this? Why are we incentivizing providers in this way, you know? And so you get a lot of different answers, and I think it depends on who you are, what your motivation is, and then also the size of the group that we're working with. So basically, we see ourselves as partners with our providers. And so when it comes to providing sort of those clinical insights that we want our providers to have, it's for our smaller providers, we have to provide that support. They might not have an EHR with the sophistication, or they might not have an analyst, you know, in their practice to be able to sort of keep track of their gaps in care and that sort of thing. So we really think of ourselves as supporting those smaller providers. And then as you go up, you know, we are more of that strategic partner with our larger providers where we have value-based arrangements and things like that. And so one of the things that we think of the program, you know, we all know we're moving beyond fee-for-service. You know, we're trying to move towards value-based care. So we feel like this program, you know, gets us going in that direction. And then last but not least, this is sort of a debate that we have, you know, do you want to keep paying providers for doing things that they do well, or do you only want to try to, quote, incentivize them, you know, to do something differently? But we do think of ourselves as just continuing to reward providers for doing the good work that they are doing too. So we kind of have a little bit of a mix and balance as we think about the program each year and, you know, what we want to put the dollars towards, if that makes sense. So our program currently, this is just what I call our fast facts. We just go with an automatically opted in model. You don't have to sign up to be part of our program. If you are a Medicare Advantage contracted provider and you have at least one attributed patient at the moment, then you're considered to be in our program, and we welcome you, and we want you to be taking care of that one member. And so we pay out, like I said, on the calendar year. So our the measurement year is the calendar year, and then we pay out annually in the next June. So like I said, right now we're working really hard to pay out 2021. That's kind of how our calendar works. I do think of our program as being largely gap focused. And so that's the ways that our providers can currently close gaps. We have the portal that you heard about that Novillis supports. And then of course the vast majority of our gaps are going to close by claim. And then we're absolutely encouraging, incentivizing, as we've all talked about here this week, the supplemental data submissions as well, and trying to get folks connected to their health information exchanges. Just a little tiny bit of history. We've been doing this since 2014. When we first started, we just had what I was told was a handful of providers. We started just by sending out emailing spreadsheets to providers with the gaps on them and expecting them to just close them by claim. But as the program has evolved, we've done a lot of new and different things. And so that original structure, like I said, we sent out gaps for HCC coding accuracy, the stars and the HEDIS measures, and there was an original, which we still have an incentive to do, preventive care visits or annual wellness visits. And then in 2020, really happy to say that we added some incentives around doing what we call personalized care support. So there's 2 different incentives in that area. We incentivize providers to have advanced care planning conversations. And then we also incentivize them to do appropriate referrals for our most vulnerable members to palliative care support, because we think that's really important and it's an underutilized service. So we want those members who can benefit from that to be referred, so we do incentivize that. And then in 2021, in order to support some of the CAPS and HOS work, we added in what we call some program unique member experience measures. So we started incentivizing providers who would report to us that they were working on fall risk management and that they were having conversations about managing urinary incontinence, and then also making sure that members are getting those flu vaccines, and hoping that by incentivizing those conversations that they would be memorable, right? When the member then gets that survey, that they'll say, yes, these are things that my provider talked to me about. And then in our program this year, we have newly added, we do our own internal survey, like I heard a lot of people say, you know, to try to mirror your CAPS results. And so we're going to actually incentivize providers who can score at the 4 or the 5-star level on 2 specific measures that we're focused on, which is the rating of your drug plan and the rating of the quality of your health care. So that's a new. Well, it'll be interesting to see, you know, how that goes. We just started that this year. And then we also now have, it's like a multiplier of your entire earnings that you can earn by giving us quality supplemental data. And again, as we've all heard here many times, you know, this is going to become key for all of us to be successful in the future, that we've got to be getting that supplemental data as they take away our hybrid measures, right? You know, can't rely on charts anymore. And so we've had an evolution of the types of incentives that we've offered. And so one of the biggest things that we did change up in 2020, we went away from an approach where we had started by incentivizing providers who reached a certain overall star threshold, and we went to a pay per gap approach. We had gotten feedback that the overall star sometimes is really hard for providers, especially smaller providers, to reach. And so it was really discouraging when they would have one measure, you know, that would knock them out of earning, or even maybe it could come down to one member, you know, one gap that could stop them from earning. So we went to this pay per gap approach that people find more engaging and more fair, to be honest. So. And then every year we do, as you guys know, this is a game of human motivation. So we look at, well, you know, are these incentive amounts really tweaking and engaging, inspiring the behaviors, you know, that we're trying to work on? And so we might tweak an incentive amount here or change a threshold there, different things like that, trying to see where we can move the needle, where we need to do that. And then, of course, as the measures are retired or as display measures are coming on, we're always trying to decide which measures we put in our program, and then, you know, which ones to remove. And then the other thing that we've done, we've gotten kind of creative with our incentive types again, in order to encourage sort of an even cadence of gap submission. We have an early performance bonus, so if you get more information to us a little bit sooner, you can earn a bonus that way. And then to also reward providers who maybe, again, can't reach that threshold, we want to encourage you to at least improve, right? So we have just maybe a smaller amount that we pay you because you improved 5 or 10% over a previous year's performance. So we do a lot of different things trying to engage people. We've talked a lot about that, you know, meeting people where they live, meeting people where they are, and we're trying to find all those different levers to achieve results. This part of the program doesn't necessarily go to like an incentive, but I wanted to tell you about it anyway because it does fall under our umbrella of our program, and I think it's a really cool thing that we do. We are able to put aside a certain bucket of money, and if a provider wants to come to us with an innovation or an idea for a quality improvement project, we are able to partner with them, and we are able to fund some of those you know, ideas that they have. And so I think it's really a great thing that we're able to offer. And so then, of course, you know, there's a lot of things they have to do to track their progress and show results and that sort of thing. But some of the really interesting things that we've been able to fund through this work is people who've wanted to pilot like for instance, an advanced care planning project where they wanted more training for all of their staff to be more comfortable to have those kinds of conversations. So we were able to fund a project around that. And then also one project that had to do with somebody who wanted to start a physical activity program for their members. So, different kinds of quality improvement funding opportunities that we've been able to support our providers to, support our members. So it's a fun, innovative part of our project. I don't think we could get together, without talking about how the pandemic has impacted all of us. So some of the things that we have had to do over the last couple of years is we have had to extend a few of our deadlines, show a little bit of extra grace to providers, because they were kind of slow on the uptake in 2020. So we extended some deadlines for them. That very first year, we actually paid out in multiple payments, trying to get money, in their hands more quickly to help them make those types of changes and pivot, the way they needed to keep providing care. So we did do that. And then I feel like our providers have done, really well getting their members in with telehealth, and we've all talked about that this week too, how that'll hopefully be one of the shining spots of this pandemic, the increase in getting members care in the way they wanted and more convenient and that sort of thing. And then I think I heard one other person say this week that they did something like this too. We also sent out our home testing kits. We sent out colorectal cancer screening. We sent out A1C testing and microalbumin testing. And so those were just ways for us to still get gaps closed, get members the care that they needed without having to go in an inpatient setting. So this is some of the ways that we've been able to adapt. And then this is what I call the fun part, the impact that our program has actually had. When I talked to our director of quality about the Medicare Quality Incentive Program and, asked, what do you think the impact has been? What are the improvements that you've seen? He said that in his mind, there's absolutely no doubt that this program has improved our star ratings. It's improved, measure compliance and that sort of thing. And he just felt that although we know that providers are all trying to do their best to do everything for everybody all the time, right? But they're just busy. And so having these extra kind of, carrots to dangle and get more attention on a certain measure here or there, we've definitely feel like we've made an impact with this program. So this was one of the bragging points when I asked, again, for different folks to give me feedback, how do you think that the incentives that we've put in our program have impacted our members? We learned that by adding this incentive, we were able to increase advanced care planning conversations by 48%. I mean, that's amazing. And then specialty palliative care referrals by 54%. And again, this is a big focus in our company that we really want our members to have their own personal goals of care met at all points, in the healthcare. And so we feel like this is really important to keep encouraging these conversations. Another bright point is the fact that ever since we've had the colorectal cancer screening measure as part of our program, we've seen continuous improvement in those screening rates. So we feel like the program has impacted that, and everyone in this room knows that obviously earlier, more screening, earlier detection, better health outcomes, which is what it's really all about. And then last, but certainly not least, we also feel like we've seen continuous improvement on all of the diabetes-related measures, and with the highlight particularly on the medication adherence for the diabetes medication, which we've outpaced the 5-star rate since we've had it in the program. So really happy with these results, and like I said, just always looking at what to put in next, you know, and where we can influence behavior. So as we look to the future and the types of things that we want to do in this program, some of the things that we've learned is that it's not a one-size-fits-all kind of world. As we were talking about, with smaller providers needing different sorts of support and help than some of our larger providers and that sort of thing. And maybe we even see some different focuses by state or by market. And so we're working on our internal technical capabilities and partnering, you know, with our vendors to try to have multiple programs, you know, maybe to do something a little bit different with the larger providers than you do with the small and that sort of thing. So that's definitely a focus of ours as we go forward, that we would like to have multiple QIPs. We'd also like to, again, improve our technical capabilities to pay out through electronic fund transfers. Currently, we do still send checks out at the end of the year. One of our state directors jokes all the time that he wants to take out big checks, you know? We don't do that, but we do still pay by paper checks, and we feel like we'd like to pay more often. And if we could pay more often, we could get more dollars into providers' hands, and then we could actually be funding the work, right? You know, they might actually be able to hire somebody to do the work, you know, and use these bonus payments to support that work. And so that's one of the things that we'd also like to do. We do want to also expand to other lines of business and not just offer these incentives in our Medicare space, but allow providers to see gaps in care for all membership. So that's a goal of ours. And then we also want to create efficiency by aligning our programs with CMS and some of the value-based arrangements that we already have in the company. So lots of work for us to do. Lots of, like I said, technical challenges with being able to, you know, run multiple programs and pay out more often and that sort of thing. But that's where we're headed in the future. So I just wanted to conclude by saying that, you know, we really want to partner with our providers. We really feel like it's the provider who can drive that member behavior. We feel that it's important to keep our members well and manage their chronic conditions. So this is one of the ways that, you know, we feel like we're partnering and providing these incentives, because we know that it's going to be the provider that's going to inspire our members to, you know, get the screenings that they need and take good care of themselves. And that's what it's all about, better outcomes for our members. So that's what I wanted to share with you today, and more than happy to take anyone's questions. And again, I'd love to hear what y'all are doing in your organizations.
Thanks, Francie. Really good presentation, really good overview. Yeah.
Can you talk a little bit about what your onboarding process is like for a new office that's going to participate, and what the ongoing support looks like for them?
Yes. So we honestly do focus on groups that have 50 or more attributed members right now. Not that the folks that have fewer than that aren't important, but we just don't have the capacity in our provider experience team to do that. And so Novelis actually partners with us, and they do outreach for us to help providers actually get onto the tool. But then we do have a team of provider experience managers who do the outreach, and they do that education and the support for us as far as making sure that all providers that have at least 50 members or more know about the program. You know, there's support for anybody else, but that's where we do like you're talking about, onboarding and actual proactive outreach. Yeah, that's it.
Other questions?
So I'm really interested to hear more. I know it was new for 2022, but about adding the 2 CAPS measures to the program. Can you talk a little bit about how, like, are you sending out transactional type surveys to members, or how that data is being collected to then apply to the program?
Yes. So we have a team that has targeted all of our groups that have 500 or more attributed members, and they've created what they call a hybrid CAPS HOS survey. So they've taken, I don't think it's every question, on both of those surveys, but they have created the internal survey, and then they send it out. And what we're trying to do is determine, that data at the group level, because CMS doesn't give it to us that way. And so yes, so they can actually, we have a vendor I think that they work with too to do that, and then they actually meet with the groups one-on-one, and they show them, here are your results from this sort of mock or internal survey that we're doing, and they give them strategies and ideas of how they can improve those CAP scores, which then we assume, will positively impact the real survey, so that's how we're doing that. It's a very targeted thing, and then we're going to incentivize them for how they did on the internal survey. Does that answer it? Okay, good. Yeah.
Anyone else? Just need to give you a live mic.
Lazy to get up. Okay. So you mentioned you pay your incentive program is per gaps closure. Yeah. So do you have a threshold for providers to reach, or is it okay? I may have, because some of the gaps will close for providers, whether they are engaged or disengaged. So do you have thresholds or no thresholds at all?
Currently, there's a little bit of a mix. So with the straight, like stars, HEDIS, gaps, there is not a threshold at the moment. That could change. But we are just paying those at a per gap rate. For like our annual wellness visits, you don't earn until you reach a threshold. For advanced care planning conversations, there is a threshold. And then for the like a risk adjustment, there's like tiers. So there's a different incentive amount depending on the thresholds that you meet. So it's a bit of a mix there. But for the stars gaps right now, it's just straight up pay per gap. You're welcome.
Any other questions? Okay, thanks, Francie. Really good stuff.
Thank you.
Okay, next we have hospital to home, integrative approach for acute care to reduce readmissions. Lauren Easton, Vice President of Innovations at Commonwealth Care Alliance. Welcome, Lauren.
Hi, good afternoon. My name is Lauren Easton. I am the Vice President of Integrative Program Development and Clinical Innovation. So happy to be here in LA. We are based out of Boston. What I'm not going to talk about, I just have to mention, I just had an opportunity early this morning to do a tour of what we refer to in Boston as a cottage community in LA. So these non-congregate cottages or small pallets, tiny homes for homeless individuals here in LA. What an incredible program. And Francie talked about the Rocky theme, and I think about the work that they are doing here in LA with this 60-bed, soon-to-be 100-bed program for homeless individuals. We just happened to start one in Boston as well as a 22-bed program for obviously a very big crisis in Boston as well for homeless individuals. But that's not what I'm going to talk about today. Today, I am going to talk about our clinical intervention, hospital to home, which is an integrative approach for acute care to reduce readmissions. First, just a little bit about Commonwealth Care Alliance. So Commonwealth Care Alliance is both a payer and a provider based out of Boston. Our foundation really started as a provider in the primary care space with an innovative model for individuals that had physical disability as well as developmental disability, and looking at an approach to care where these individuals generally would be institutionalized, but an innovative approach breaking down barriers to care so folks could live independently in the community. We have expanded Commonwealth Care Alliance since the 70s as that primary care approach to both the payer and provider, a health plan. In Massachusetts, we have recently moved into Rhode Island, as well as actually California and Michigan. I'll be primarily talking about our programs in Massachusetts, but currently in Massachusetts, we have about 40,000 members. Our members are dually eligible for the most part, so we are eligible for Medicare and Medicaid. We have a one-care program for dually eligible under the age of 65 and a senior care option program for over the age of 65. We really have a history of treating the most complex individuals in the state of Massachusetts who often have barriers to care, often are very difficult to engage, don't have access to care. So really focus on innovative approaches to engagement, meeting people where they're at, coordinating care, developing relationships, and ensuring people have access to care. In Massachusetts, we have 7 offices where our interprofessional teams are able to have space, drop-in space, space to work. We have 2 primary care and engagement centers, what I describe as reimagined primary care for individuals with the most complex needs. The majority of our individuals do have primary care in the community, but we also have complex primary care sites. We have currently 1 crisis stabilization unit for individuals that are in acute psychiatric crisis. We had 2 through the pandemic. We did have to shut 1 down because the hospital was repurposed as a COVID site. And what I'm going to focus on today is our hospital to home program. This is our program where we have doctors that are integrated into 4 of our busiest, highest utilizing hospitals across the state of Massachusetts. And just a little bit more about our approach and what we refer to as uncommon care. Because the population that we serve, the most vulnerable, often incredibly traumatized by just the system and gaps in the system, not engageable, difficult to find. We have really a community focus to ensure the most appropriate site of care. We want to meet people where they're at. Every individual, every member that we see has a care partner, as well as an interprofessional team that consists of behavioral health, health outreach workers or community health workers, OT, PT, and an RN. So depending on the individual's need, they have access to their care partner. They're really driving their care through their care partner. But in addition to that, they have a team of interprofessional folks that can see them in their home, at one of our facilities. We deliver care throughout the continuum of care. So if somebody's in the hospital, if somebody's inpatient in a SNF, somebody's in our psychiatric crisis unit or psychiatrically hospitalized, our team of professionals is meeting with, coordinating care, collaborating with every point of care in the system. So really just in terms of our trusted partnerships with not only our members, but our providers in the community, human service providers, CBOs, hospital systems, we're able to reduce gaps in care, decrease ED visits and admissions and readmissions, and really have a very high level of provider and member satisfaction. So our hospital to home program really focusing on decreasing admissions and readmissions. It's a patient-centered and coordinator care model where in the actual EDs and inpatient settings in 4 hospitals. What we do is our CCA doctors are integrated into the actual ED and partner with an ED doc to make shared decisions about a member's care. So generally, when our patients hit the ED, because of their complexity, whether it's medical or psychiatric, the automatic reaction is often to put them inpatient, do as many tests as possible. With the support of our doctors and our health outreach workers, we're able to make shared decisions. Again, due to the nature of the complexity of our members, ED docs are reluctant to transition or divert people back to the community without knowing about alternative resources. And so our doctors and our health outreach workers are able to work with the ED doc to think about, here are the alternative resources. We have a psychiatric unit. We have health outreach workers that can meet people in their home. We have nurse practitioners for an acute care in the home that can see them immediately within 12 to 24 hours. So we offer alternative resources instead of a very often pricey inpatient stay and unnecessary testing. Again, only because the complexity of our members, it's difficult to make that assessment and divert back into the community without the support of the community resources. So CCA members, in real time, our doctors are notified that we have a CCA member at the ED. Actually, I'll move to the next slide. So the patient presents to the ER. The hospital home team is automatically notified. The patient is evaluated by the ER team, and the CCA, MD, and HOW, we also have behavioral health and recovery coaches that are available at all of our EDs, are working directly with that doc to make that decision. So one route, obviously, is somebody could be admitted for further care. We're also following that person in an inpatient setting and supporting the team on the inpatient setting for our members. We're able to consult. We're able to help with transitions back to home and support them upon discharge. And again, the other alternative is looking at alternative community resources. And our clinicians in the ED to home or our community teams can follow that person in the community to ensure that they're safe. So we're able to really divert a higher level of acuity to the community. Many times our patients are frequenting the ED. Through this model, developing this relationship in this acute care setting, we're able to decrease those readmission and admission rates. Through our experience at Hospital to Home, as I mentioned, we have primary care sites across the state. We really decided we needed to reimagine our primary care. So co-located with all of our primary care sites, we have what we refer to as our engagement centers. So again, this is a place where people do not actually have to be involved in our primary care. It's for all of our members. We utilize the Hospital to Home care team to be able to divert to our engagement centers where they can address their housing needs, their food needs, their substance abuse needs. We're able to start them on MAT, address their behavioral health needs, connect them with peers. We also have recovery coaches that are incredibly significant with our population in terms of care. And it really can also be, I don't want to call it a, quote, just drop-in center, or not just, but it really does have structured programming, but it allows people also to come and socialize. So often with our population, again, they're hitting the ED because they're lonely, cold, hungry, anxious, depressed, but really need and can get the support in the community. So in terms of assessing a member's broader needs, as somebody hits the ED, our staff are able to look through their chart, see if there are any assessments or screening that has not happened, that whether they're due or overdue. We have passive enrollment for our One Care program, so very often people are coming in and they're so difficult to find. We don't have right addresses or phone numbers, and we have to do an in-person, and we do all in-person assessments, initial assessments, so we're able to capture that person, we're able to start a relationship, build a relationship, and schedule appointments for whether a assessment that's due, an overdue assessment, a screening, so really able to make that in terms of a point of care, when often it's a barrier of care because people are jumping from ED to ED, we're able to start that relationship and start those assessments. Substance use treatment. Again, just in terms of both the initiation and engagement treatment, we have found in the past that's been incredibly difficult for us to meet that measure. When folks now hit the ED, we have our recovery coaches, we have our behavioral health we're able to start linking people to treatment, whether that's in a hospital program, a detox, one of our own clinicians in the community. We're able to facilitate those services for that person. Oftentimes people need detox. We're able to facilitate treatment in a bed for the person. As I mentioned, recovery coaches in the ED, starting that relationship with many folks. About 35% of our population has a substance use disorder, but able to start them with a recovery coach in the community. And the harm reduction, we're able to give people Narcan for people who present with overdose. And if people come in with somebody, we're able to also provide them with Narcan. And chronic disease management. We have chronic disease management groups through our engagement center. So if folks are diagnosed with most of our folks have 4 or more chronic diseases. So we have groups focusing on diabetes and heart failure. So we literally can walk people over to the engagement center, to our Reimagined Primary Care, and introduce them to this group. So a 5-week group providing information on symptom tracking and action planning, eating a healthy diet, understanding medications, and communicating with providers. Primary care. So many of our folks they have primary care on paper or don't have primary care. So we're able to connect them with our primary care or follow up with a primary care in the community. For folks that don't have primary care with us, our NPs really act as a liaison or a partner to primary care. So through the hospital to home program, we're able to, again, better coordinate, better collaborate with primary care. If there are tests or labs that have been requested and they haven't had them, we're able to coordinate that while in the hospital or in the ED. So really just through our uncommon care model, CCA has really been able to see a very high patient engagement rate, again, based on our population with the most difficult folks to engage. We have a 92% engagement rate. We have a 5-star program for our SCO, our rating for our SCO program. Our consumer experience score is at 89%. We've seen a big reduction in long-term acute care, just being able to serve people in the community, serve people where they're at. Through our crisis stabilization unit in beds and also our teams in the community, we've seen a 20% reduction in inpatient psychiatric and substance use. So again, our hospital to home program is really just a fantastic way to start engagement, continue engagement, reduce those admission rates, reduce readmission rates, and then connect people to very important services, screenings, engagement for substance abuse in the community. And that's it. Any questions?
Questions? Oh, sorry.
Great presentation, by the way, and that's why we are, I believe, in the healthcare arena to be able to help our members like this. But some, let's say, implementation or how do you operationalize this plan? So you mentioned it's hospital to home, but at the same time you said that because the whole point of value-based care is to bring the primary care provider as the center of attention so that it's not one-time visit or it's not engaging the member when they are in the hospital. So what sort of if your hospital to home team is involved with after a member had reached home aspects of the business as well?
Yeah, so the team is involved. So the hospital to home team follows the person at home. So depending on what the diagnosis is, what the issue is, if they were either discharged from inpatient or diverted from an inpatient stay, we continue to follow them in the home. So whether that's a nurse practitioner, a health outreach worker, or a behavioral health person, we are able to access and continue that treatment or engagement in the home. But additionally, CCA has care teams in the community. So as we transition and bridge that care for, say, 1 week, 2 weeks, 3 weeks, we're also then collaborating with the community care team to continue that treatment in the home or in the community.
Got it. And do you know how many members actually got readmitted after being in the hospital to home program? What's that stat?
Yeah, we have reduced our readmission rate by, I believe, and it varies across each hospital that we're in, but I would say by 24% in our highest utilizing hospital.
Awesome. Okay, so your community care plan also works, not just hospital to home. Your community clinic is also doing an awesome work.
Yes, so, and we collaborate with our community care team. So again, as a payer and a provider, and we really do focus on our clinical teams in the community.
Okay.
And it is important to the hospital to home team to have that continuity of care and that
Yes.
continuum of care in the home for sure.
Got it. But are you also working towards attributing the members to the primary care physician as well? Or do you believe that based on the demographics or members you have in your thing, its community engagement will be more effective than just the PCP care?
Yeah, so I think that, so we have very good in our network of providers, we have really good relationships with our with primary care. But again, because of our population, oftentimes our primary care almost becomes the primary care of default because of the complexity and the nature of our patients. So we're not trying to attribute all of the patients to our primary care. We don't want to disrupt any current relationships. However, if somebody has been fired from their primary care or really needs the specialty practice that we provide, we do a lot of in-home care, which many primary care practices do not do. So we're able to provide that when people have barriers to coming into our facility. We're able to do that work in the home. So it's an opportunity for people to become connected to primary care, not necessarily a strategy for us to grow our primary care, but certainly availability. I'd say just as important, we want to collaborate more and intensely with primary care providers in the community.
Sounds good. Thank you.
Sure.
Another question?
I'm curious if the hospitals that you went into were the ER docs and those sorts, were they like, yes, please come in here and help us with these members, that we may not know as well as you? Or was there, I hate to say this, like any resentment of an insurance company trying to tell us what to do with a, I don't know that dynamic that well, and I'm just curious what your experience was.
I think that's a great question.
I think what you're doing is amazing. I want to be clear on that, but I just know docs a tiny bit, and I just wondered.
No, that's a great question, and I should probably include that in our presentation, because it takes a while to build that trust with the hospitals. I think it's both. There's one large hospital that we have worked with over years, for 20 years, and that hospital, it was a lot easier to go in and arrange this. We, in fact, used to have a whole floor for our very complex folks, and our hospitalists would round on the floor. So that hospital, it was a little bit easier. That trust was built, that relationship was built. The other hospitals, it's taken about a year. We've recently integrated behavioral health into our hospital to home program. And again, it's supporting the hospital and getting those very difficult diagnoses and quick either diversions, and of course, it's a fine line, because hospitals are filling their beds, and we want our members in appropriate levels of care. The other thing I think that they're very happy about when we do come in is, in Massachusetts, I'm sure everywhere, we have a huge issue with boarding, folks boarding in EDs. So we have an average rate of boarding for 8 days. So it can be very challenging for hospitals to place people specifically in the psychiatric setting, but there is an issue of boarding. So I think it's both. It takes time to develop the relationships. I think that they are very happy to have the support and be able to identify people that are able to actually be treated in the community or even discharged earlier because they've got access to the alternative resources. But it's a great question. It has taken us, and there has been 1 or 2 hospitals that have said to us, no, we're not ready for this. I'll say there was one other model in Massachusetts that we've done, and this has been great, where at Beth Israel Hospital, we have actually hired their hospitalists, their ED docs for CCA. So 5 of their docs that work in the ED work for us in our hospital to home program. So they're already integrated into the systems, they're already integrated into the program, but for part of their job, they actually work for our hospital to home program, identifying individuals that could be diverted. So that was a pilot, started in September of 2021, and it has worked out fantastically. We will renew that and extend that and think about as we move forward with other hospitals, if that will be our approach to hospitals.
Any other questions? Okay, thank you.
Thank you.
Hey, before I forget, if you have not filled this out, would you please fill it out? It's just 3 simple questions. It'll be really helpful for SSN. Thanks. And last session, right? So we will turn it to in-home interventions, meeting members where they are. Haley Kessler, Star Ratings Manager at Health Alliance Medical Plans. So welcome, Haley.
All right, well, thanks everyone for sticking around. My name is Haley Kessler, and as Rex said, I'm the Star Ratings Manager for Health Alliance Medical Plans. Just to give a brief kind of background on myself, I've been in the healthcare space for almost 8 years. But I have held several different roles. I've done reporting and analytics for the health plan, Health Alliance, which I'm currently with. I've also worked for a provider group doing some performance improvement work. And then most recently came back to Health Alliance in my current role. So just wanted to give everyone kind of a brief overview of Health Alliance, who we are. So we are based in downstate Illinois, so central Illinois, we're in Champaign, so University of Illinois, if you're familiar with that area. We have our largest member base in the Midwest, so you can see Illinois, Iowa, Indiana, and Ohio is where our bulk of our membership lies. We also do have Health Alliance Northwest out in Washington State. And we serve, you can see, variety of different populations. I will comment, we've heard a lot about the DSNP and Medicaid kind of sprinkled throughout the conference. We previously did have a Medicaid product, but a couple of years ago decided to discontinue coverage of that product. So we have a total membership of about 240,000 members that span across these various states. But specifically want to just kind of hone in on that Medicare Advantage membership is right around the 50,000 member mark. So we do have one additional affiliate who is not mentioned in this slide, First Carolina Care, out in North Carolina, is also affiliated with Health Alliance Medical Plans. So across all of those various entities, we have 6 H contracts. All of those were at 4 stars for the 2022 ratings. And then I will also mention we do have one PDP, and that has been at 5 stars for the last couple of years. Also worth mentioning that our organization is part of a vertically integrated health system. Carle Health is our parent company. So I just like to share this slide to kind of illustrate, we've talked a lot about interoperability, and, I think being part of an organization that is vertically integrated lends to some, lends itself to kind of setting us up for some additional successes as we move toward that in the future. So, we've heard a lot about social determinants of health, health equity, hot topic of conversation throughout the last couple of days. So just to kind of bring everybody back, we really think about, traditionally, there's 5 different domains of social determinants of health that you can see here. So, of course, economic stability. Do our members have jobs? Are there food and housing insecurities that we're aware of? Education access and quality, of course, how high or what is their highest level of education? This is also where we would see the language and literacy come into play. Health access and quality, how literate are our members in understanding the health care that they're receiving? Do we need to think about how we're delivering our messaging to them? Of course, neighborhood and built environment, talking about crime rates, violence, the quality of housing. Can they easily access food that is healthy or supports a healthy lifestyle? And then, of course, social and community context. So really, all of these things historically, while they're not directly, related to healthcare, there are definitely things that impact our members' ability to seek and access healthcare. We've also talked about EPIC a couple of times. So our organization does support EPIC on both the payer and the provider side. So EPIC, I just wanted to kind of highlight, they've taken those traditional social determinants of health and broken them down even further. So they use 10 different domains, which you can see highlighted up here. I think some of the things that we've really highlighted on transportation needs, social connections, food insecurity. So they've really got kind of a unique breakdown here. But to put it into perspective and kind of the direction we're going here, within EPIC, they have this wheel. So as we gather this data on our members or our patients, these questions filter into this wheel. So based on how members are answering our questions, they fall into, within each category, either a low risk, a medium risk, or a high risk. So then we can really utilize this data within EPIC to help us understand and drive members towards benefits that will impact areas that may be of the highest concern for them in terms of their health care. So knowing kind of that information about our members, knowing what may be impacting their ability to receive care. A lot of the things that are impacting their care, so for example, transportation issues. We really wanted to look at, well, what can we offer members in their own homes to help support their health care? So I have 3 different initiatives that Health Alliance has taken on. Just wanted to share those all with you this morning, or this afternoon, I guess. So social isolation can really have a big impact on several different areas in terms of how it impacts stars. So we've partnered with a vendor. We allow members 30 hours annually, and this vendor sends in a individual into the homes of our members. They can do things like offering support for companionship. They can help with tech support, housing tasks, so light cleaning, remove, kind of tidying up care gap reminders is also a big thing. They, through their conversation with members in the home, can do things like reminding them, hey, I see you haven't scheduled your mammogram. Can I help you call your provider? Can I help you get that scheduled? And then transportation, I think, is a big one here. We see that our members are utilizing this particular service for transportation to doctor's visits, to the pharmacy, to go grocery shopping, things that they may not have been doing just because they didn't have the resource to do so. And what's really interesting, and I think we've really only scratched the surface of this, is we do receive back, I call them member escalations here. We get those back monthly from this vendor. You can see here on the graph that I've kind of they break it down into some really big buckets, but you'll see fall risk is really kind of a area of opportunity for us. We're gonna take this information and as we look at it, decide are our benefits supporting these needs of the members? Can we give members what they need in order to be successful? So, we're really taking a closer look at some of this information, but in the kind of immediate short term, what we do once we get that data back, we send that over to our care coordination teams. We have a representative who, so to speak, will triage these referrals or escalations back to us to say, in this model, we have several different programs within our care coordination space. So which model would this member best fit into based on their needs that were detailed within the referral. Typically, what we are seeing is our members really fall into our complex bucket. So these are really our high-risk members. Typically, they'll have several chronic conditions. And then we also will see a lot of the referrals going back to our social work team. So I've just got a couple of examples. From those referrals, we've had recently had 3 members enroll in care coordination. They're working on things in their care plans, such as the fall risk, making sure they're taking medications appropriately. And then with our social workers, they're able to connect members with community resources that support their concerns. So things like, resources to combat unsafe things within the home. So I know we've had some referrals for like bugs in the home. So we've got community resources that can assist our members with things like that. And so here's the numbers. Here's really where we see the impact. So of our population who is eligible for this, we've currently are sitting at a 4% program enrollment. And in quarter one, we saw a ROI of $2.14 for every dollar we spent. This vendor also provides us with information on where we're seeing the greatest return. So of course, social support is number one, but we're also seeing gains in the member retention space and also healthcare access and compliance. We're getting members to the doctor to close those gaps. And then just a couple of testimonials here on the side. I always love a feel-good moment. So seeing these things come back from our members, that the work that's being done in their homes, these individuals who are supporting them really are making an impact. Another in-home intervention we've done, and I apologize for the incorrect HEDIS measure ID, it should be COL. So forgive me for that. We have deployed in-home test kits, which we've heard a couple of other presenters speak to as well. So I just wanted to provide some information on our particular program. We launched in 2021, kind of in the middle of the pandemic, seeing members, hesitant to go in for their screenings, or providers were so backed up trying to get through the backlog of members that occurred as a result of COVID. So our criteria in 2021, we sent out 1,750 kits to members. Members had no record of a screening with us. or we did not have record of a member receiving the screening. The members had to have an attributed PCP. We wanted to make sure we were able to provide those results to the PCPs of the members. And we utilized reminder letters and robocalls to supplement that program. So you can see we really had very good participation. We deployed kits in both our Midwest and Washington markets and had a 26% return rate for both populations. So really, really impressed. The vendor that we do partner with on this, I believe their book of business return or participation percentage is around 23%. So really, we were very excited to see that success. Then, of course, I wanted to also call out our alert rate. So those were members who did have tested positive for blood in their stool. So you can see that both were close, both regions were close to that 12%. So looking forward to this year, what are we gonna do a little bit differently? What are we gonna do to challenge ourselves? We've expanded the number of members that we're going to deploy kits to. One thing of note is that we are going to include anyone who did return a test kit last year. Easy win, they've already, we hope, we've already got them kind of in step with that, and want to make sure that we get them again for 2022. We are going to add, though, a couple of additional reminders. They're going to get a pre-notification kind of telling them more about the program. Hey, you've been selected to receive one of these. It will be coming. And then we also are adding in some digital mediums for reminders as well. And I always really, we like to show this slide when we talk about this program. It's great to know, well, what am I doing with my HEDIS compliance rates, right? But really, when we look at it in terms of human impact, we can see over on the left here that based on data from the sources listed here, that for every 1,000 members we screen, we prevent 26 deaths and we have 26 deaths potentially, and then we could potentially lose up to 318 life years. But with our program in 2021, we did see a 2.5% increase in HEDIS, and we screened an additional 458 members. So doing the math, we can see that with our particular program, we prevented 11 deaths and added 145 life years. So just like to show this to really see, what is the impact of the work we're doing for our members. And then the last thing that I'll just touch on, we do offer a post-discharge meals program. So with this program, members are eligible to receive two meals daily for 2 weeks post-discharge. And we do target this one to members who have at least one or more chronic conditions. But a couple of things that are really interesting about this particular program. We did see that this really had a good impact or a significant impact on all-cause readmissions. We have seen over the past 3 years, we've had this program that our readmissions has decreased by 4%. So it's definitely making an impact. But what I do want to call out and what I think is really interesting about this program is that upon analysis, we did see that our inpatient and ED utilization for the members who do take advantage of this benefit is higher, as is the RAF. So, as we dug into this a little bit further, we're seeing that members who, have less social support, have very complex or several social determinants of health needs, are the ones who are more frequently taking advantage of this benefit. So as we look forward to the future, using what we've learned with this program, I'm looking to potentially offer additional benefits that support, food insecurities or other programs related to supplying food to our members. So that's
those are the three kind of big in-home interventions that we leverage. So happy to take any additional questions that the group might have.
Any questions? Good presentation.
For your fit kit testing, I'm wondering if the driver for the pre-letter is to screen out the members who aren't appropriate for a fit. Is that a part of your letter, or is that something you're doing in a different way?
Yeah, that's a really good question. So we are, I'll back up. So when we identify members that we would like to target, we are actually using, I've seen it mentioned, Unite Us. So we look at our non-compliance data from Unite Us, and then sometimes in one of those two groups we had previously, we did filter out or filter down to those who are likely to participate in in-home testing. So we're kind of doing that filtering prior to, to get rid of members who likely wouldn't be a good target for those kits. We're doing the filtering prior to that pre-notification letter. So that letter is really going to be leveraged more to say you've been selected, kind of prep them so they don't just get this kit in the mail and think, what the heck is this? What do I do with it? They've kind of been primed for that. So that's really the goal of sending that out initially.
Thanks for the presentation. Great work, by the way. So my question is in regards to the social support program. You said 30 hours are assigned for each member, and the program participation was at 4%. So what's your criteria of pulling the members into that program?
Yeah, that's a really, really good question. So currently, there is no criteria to be eligible. It's if you are on Plan X, you have this benefit. I will say though, as we look forward to 2023, we are talking about how we can look further, like should we be looking at people who have multiple ED visits, are at risk for readmitting, things like that. So we're looking at ways where we can really kind of hone in and specifically target our marketing to those individuals.
So for the 4% you currently have, was it based on some sort of, your QM team doing some HRA and then deciding this member is a good candidate for this program?
Yeah, so that 4%, we relied on, so just to kind of give a overview, we at the health plan sent out our marketing materials to those who are eligible, but that 4% is simply just from outbound dialing by the vendor we're working with. Now, I will say if we do have members who are enrolled in our care coordination programs and a care coordinator feels that they'd be are eligible and would be a good fit, we do warm transfers over to get them enrolled in the program as well.
Do you have, just like you showed the data for a fit kit, that you were able to prevent 11 deaths and things like that, do you have any sort of metrics available for that social support program as well that reduced the ED visit or whatever the positives or negatives came out of that intervention?
Yeah, so I just kind of gave the high level information, but the vendor does give us a nice breakdown with the dollars, and then also tells us how many visits the members that are enrolled have had, or how many hours they've used of the service.
That's good, thank you.
You're welcome.
Another question back here.
I'm curious about the 30 hours that, each member is allotted, and I was trying to think, how would they use that? Do members go, oh, I want someone to come and visit me for an hour once a month, or do people use it up and then they're sorry they don't have any more hours? I just wondered how the 30 hours was selected and how's it going? Like if you're like, people wish they had more time, or you know, how are they utilizing that 30 hours?
That's a really good question. So we've kind of seen a varied, in the data that we've received so far, we've seen a varied use, I'll say. So we do have a couple members that, 5 months in have hit their threshold, and fingers crossed, haven't heard any complaints yet from them. I hope it stays that way. But then, of course, we have members, like you mentioned, who use it so that every 3 weeks they have someone come for an hour just to play board games or, go for a walk with them and their dog or things like that. I will say that we do offer, I say we, but if a member does run out of hours, they do have the option, if they choose to do so, to self-pay. But we are looking at, as we consider, kind of what do we want to do we want to expand the program, are looking at that hours utilization. I think it's a fairly new program for our organization, so wanted to start on a smaller scale in terms of hour allotment, but I'm hoping in the future we'll be able to increase that and offer more to our members.
Other questions? That's it. Thank you, Haley. All right. I'm lucky I didn't trip any, right? Like doing that. All right, that's it. So thanks so much. Thanks SSN. Thanks Audrey for putting this on. It really was a good conference. Great topics. I really felt like great presenters. A lot of presenters I'd never seen before that I was definitely happy to see and impressed with. So great conference. So looking forward to the next one. And please fill out your form if you haven't and leave it behind, and that'll be super helpful for SSN. Thanks for everyone virtually tuning in to us, and safe travels back home. So thanks everyone.